Psychiatry as internal observer as per APMC regulations. Thanking you, ma'am, for accepting our invitation. And now we shall start today's session with a pre-test. All the postgraduates kindly participate actively. I request Dr. Sunita to please give the pre-test sheets to the postgraduates. So the pretest is designed just to assess the baseline knowledge. Then after the academic sessions, I hope this will completely, we ensure that you could answer all the pretest questions.
Thank you, ma'am. We now proceed to the pre-inaugural session, which sets the academic tone for the day.
The pre-inaugural session is titled Endoscopic Findings in Neoplastic Gastrointestinal Lesions.
This session will be delivered by Dr. U. Vamsikrishna Sir, MD, DM, Assistant Professor, Medical Gastroenterology, Jensen Hospital.
We request Dr. K. Pratyusha Ma'am, Assistant Professor, Jensen Hospital, to kindly come forward and address the gathering with a brief introduction of Sir.
Good morning, one and all. It's my privilege to introduce our esteemed speaker, Dr. Vamsi Krishna Sir, who is working as a consultant medical gastroenterologist in GEMS Medical College and Hospital. Sir has pursued his MBBS, MD, and DM in Andhra Medical College. He has comprehensive training and hands-on expertise in both diagnostic and therapeutic GI endoscopy. His skill expertise includes upper and lower GI endoscopy, colonoscopy, endoscopic variceal ligation, stricture dilations, argon plasma coagulation, and polypectomy. He has special interest in GI malignancy workup and surveillance, as well as IBD management. We are indeed fortunate to have him share his knowledge and experience with us today. I now invite Dr. Vamsi Krishna sir to kindly take over the session.
Good morning, everyone. Thank you for inviting me for this CME. So My topic is endoscopic findings in neoplastic GI lesions. This is not a clinico-pathological correlation. It is just like an endoscopic pathological correlation. So object of my talk is to correlate endoscopic appearance with histology, to understand the narrowband imaging or chromoendoscopy predicts how this narrowband imaging or chromoendoscopy predicts the dysplasia, and to highlight what pathologist should look for in a biopsy specimen. Why endoscopy matters? Endoscopy predicts the histology. It guides site and number of biopsies. It also reduces the false negative biopsies. It also determines whether to go for an endoscopic mucosal resection, endoscopic submucosal dissection, or surgery based upon the depth of invasion. So we as a endoscopist, we look for macroscopic appearance, but pathologists should confirm the microscopic diagnosis. It is a teamwork where the final decision should be taken combinedly. Look at this image. This is an image of a distal esophagus. This is a polypoidal or a fungating lesion present in the distal esophagus. Anyone can identify this has a problem and you have to do a biopsy. This looks like a neoplastic lesion. Similarly, this is also a polypoidal growth or a fungating growth in the distal esophagus. So even a layman can understand this has a pathology, and and endoscopy should do a biopsy and it should be sent for the histopathological confirmation. See this image. The left hand side of the image shows that this is also a distal esophagus. There is a elevated lesion. In the left hand side, there is an elevated lesion with a reddish margins. On normal white light endoscopy, this image appears to be normal. This is a magnified image showing that there is an ulcerative lesion, that is an elevated ulcerative lesion in the distal esophagus. So to confirm these kind of subtle lesions, there is a investigation known as chromoendoscopy. Chromoendoscopy is of two types. It is dye-based or a digital-based. In a dye-based chromoendoscopy, there is a chemical substance is sprayed into the mucosal surface of the gastrointestinal system to highlight the specific mucosal surface or the microvasculature, mucosal surface. There are three types of dye routinely used. One is absorptive dye, where this dye takes up the glycogen in the mucosal layer. There is a non-absorptive contrast dye where the dye do not take up any of this glycogen, but it demarcates the surrounding mucosa or interepithelial crypts. Whereas the reactive stain based upon the color change, we can identify there is a pathology. Whereas coming to the distal chromoendoscopy, there is a specified software systems where the electronic contrast enhancement will say there is an abnormality in the GI mucosa. There are three different types of distal chromoendoscopy. One is narrowband imaging, which is a proprietary of Olympus. In this narrowband imaging, it uses green and blue filters. The blue filter, which is of shorter wavelength, will stain the superficial capillaries, whereas the green filter, which is of longer wavelength, penetrates the deeper mucosa. This will create the contrast in enhancement so that the superficial layers and the mucosal surface can be identified clearly. Now, brief description about the Barrett's epithelium. Barrett's epithelium is nothing but an acquired condition where the metaplastic columnar intestinal epithelium replaces the normal stratified squamous epithelium. To diagnose the Barrett's epithelium, it should require one is endoscopic appearance, another one is histological confirmation. On endoscopy, this is the normal GE junction. In the normal GE junction, the gastric fold, the normal columnar epithelium shouldn't extend more than 1 centimeters. That is, the columnar epithelium will look as a salmon colored appearance. This shouldn't extend more than 1 centimeter. This is the normal lower esophageal picture. But if the salmon colored or salmon pink appearance of the mucosa, which extends more than 1 centimeter, it is nothing but the Barrett's esophagus. It can be labeled as short segment or a long segment based upon more than 3 centimeters or less than 3 centimeters. See this image? The salmon colored appearance extending more than 1 centimeter. This is nothing but the Barrett's epithelium. There is a classification system known as PROG. This PROG classification system, routinely we use short segment or long segment Barrett's epithelium, but this PROG classification will say it is universal, and it will say that the maximum extent, if the extent of the lesion is more, it says that the invasion is more or the dysplasia is more. And it also says, it also guides the clinician to take biopsies from the lesion. So PROG system classifies as C and M. CM is a circumferential mucosal extent, whereas M is a maximal mucosal extent. So to identify these pathologies, by using NBA, we have to look for mucosal surface. Another one is mucosal vasculature architecture. The mucosal surface of the Barrett's epithelium is circular, villous, gyrate, or tubular pattern, whereas the vascular architecture is along the mucosal surface. See this endoscopic appearance of the distal esophagus. In the endoscopic appearance of the distal esophagus of the Barrett's epithelium, see the architectural pattern. This architectural pattern is circular or gyrate or villous, and the mucosal vasculature is regular, arranged regular to the mucosal surface pattern. So, on endoscopy, this is normal. Similarly, this is the distal esophagus picture showing that on NBA, there is tubular or villous type of mucosal surface with the circular mucosal vasculature. This is a regular pattern. So these two images shows there is a Barrett's epithelium without any dysplasia. Coming to this picture, the green arrow shows the regular pattern, whereas the yellow arrow shows there is distortion of the mucosal surface without any vasculature. This says there is an abnormality in the Barrett's epithelium. On biopsy, you can find there is a dysplasia. So coming to the image, this is an image which looks like normal on white light endoscopy. This is a Barrett's epithelium where the Prague classification of C2M5. This is the NBA of this normally appearing on white light endoscopy image. On NBA, the appearance is normal surface architecture. On biopsy, it showed Barrett's esophagus characterized by columnar line mucosa. There is no dysplasia. Similarly, this is another image of Barrett's epithelium of C2M5. This is the NBA picture of this epithelium. In this, there is no mucosal pattern, there is no vascular pattern. It is haphazardly arranged. On histology, you can find there is presence of high-grade dysplasia. So by seeing the NBA, you can identify the subtle lesions of the Barrett's epithelium. The normal, regularly arranged Barrett's mucosa will say it is normal. If it is haphazardly arranged or absence of vascular pattern, we'll say there is an abnormality. It guides the clinician to take the biopsy and send for histopathological confirmation. Next, coming to the lesions of the esophagus. This is the normal esophagus. In the normal esophagus, anyone can say there are superficial vessels which are present on the mucosal surface. These superficial vessels can only be seen on white light endoscopy. So coming to how the vasculature is arranged, from the submucosal vessel, there are branching vessels. Up to these branching vessels, one can see on white light endoscopy. From these branching vessels, there are presence of obliquely running vessels and intraepithelial capillary loops. These are nothing but IPCLs. By seeing the IPCLs, you can say there is an abnormality or not. See, there is a classification of IPCL. IPCL type 1, 2, 3. The image showing IPCL type 1, 2, 3 is normal, whereas IPCL type 4 recognizes the high-grade dysplasia. IPCL type 5 will say V1 and V5 type 1 and type 2 will say it is mucosal squamous cell carcinoma. Type 3 will say submucosal invasion. So by identifying the IPCL, whether it is having 1, 2, 3, 4 or 5, you can identify the lesion. This image of NBA shows type 5 IPCL. In type 5 IPCL, the capillary loops are dilated, tortuous, and it has different types of shape. So mucosal disease will determine whether it is having a mucosal disease will say whether she should go for a EM or ESD. Some mucosal disease will say that the patient should go for a surgery or not. So this is an image of a esophagus of mid-thoracic region that is of 20 centimeters from the incisors. There is a flat lesion of approximately 2.5 centimeter in the mid-esophagus. On NBI, you can identify type 4 IPCLs. Type 4 IPCL is nothing but it is a high-grade dysplasia. By histological confirmation, we can say the patient is having high-grade dysplasia. This is another image of the mid-esophagus where there is a slightly raised lesion of 15 mm with erythematous margins. On NBI, we can say the patient is having type 5 1 IPCL. This type 5 1 IPCL will indicate that the patient is having mucosal lesion. On histology, we can confirm there is a superficial squamous cell carcinoma limited to only mucosa. Coming to this lesion, there is a protruded lesion in the mid-esophagus. On NBA, it can identify type 5-3 lesion. On histopathological examination, we can say there is a submucosal invasion. So by identifying the NBA pattern, even the subtle lesions, you can identify the histological appearance on endoscopy. It should be confirmed by pathologist. Next, coming to the gastric lesions. To understand the gastric lesions, you have to understand Paris classification. Paris type 1 is a protruded lesion. Paris type 2A is a slightly elevated, which is a flat lesion, which is slightly elevated. Type 2B is a just flat lesion. Type 2C is a slightly depressed lesion. Type 3 is a excavated lesion. The type 2C and type 3 will say there is a submucosal invasion. See the microarchitecture. The crypt opening appears as a dot. The intraepithelial or intervening part can be seen in the image. If it is regularly arranged, it should be circular pattern. But if there is an irregular arrangement of this intraepithelial part or crypt opening, there is an irregular arrangement seen in the white light endoscopy. Similarly, you have to see for the capillaries. The capillaries should be normal caliber throughout the mucosal surface. But if there is any change in the caliber, you can identify there is an abnormality. Similarly, you have to look for heterogeneity in the shape. That is the tortuousness of the vessel wall, density of the vessel, and heterogeneity, change in shape, which can be partial or complete. This is the heterogeneity in shape, which is a partial and complete heterogeneity. On NBA, you can see there is heterogeneous microsurface appearance. In right-hand side, you can see there is an amorphous layer. There is absence of microsurface appearance. So by identifying the mucosal surface, by identifying the vascular pattern, you can identify the abnormality. So this is a retroflexed view of an endoscopy showing the fundus and the body. In the retroflexed view, on NBA, you can identify there is circular mucosa with surrounding regular vessels. This is the antral gastric mucosa on endoscopy. On NBA, we can see there is reticulate shaped. This is normal appearance. On body, we can say this is circular shaped. In the antrum, we can say it is a reticular shape is normal. So the normal pattern is rounded pits in fundus and body and reticulate pits in antrum. So by seeing this pattern, you can identify the histology as an endoscopist. But you should confirm later, but we can identify histology as an endoscopist. In a normal gastric mucosa, the mucosal microsurface should appear as regular and the microvascular surface should appear as regular. Whereas in intestinal epithelium, the microsurface and microvascular pattern just alters. Similarly, in adenoma also, there are regular and irregular arrangement but densely packed. In an early gastric cancer, there is irregular microsurface appearance and microvascular pattern. If there is an irregular microsurface appearance or microvascular pattern, you can say it is an early gastric cancer. So these are the images showing the left hand side showing the regular pattern of the antral mucosa, and the middle image showing an irregularly arranged surface with irregularly arranged microvascular pattern. In distant right hand side, you can say there is an absent microvascular pattern and microvascular surface. So this is a lesion in the pylorus. There is a protruded lesion in the pyloric ring. There is two lesions. The blue lines encircles that normal pattern, whereas the yellow border will encircle there is an abnormality or depressed lesion. On magnified image with the NBA, in the NBA, the blue area will show regular pattern, whereas the downward lesion will show irregular pattern, irregular absent or irregularly arranged microsurface pattern. So on histology, the blue line, which appears as a normal on endoscopy, will show hyperplastic lesion, whereas the red line will show cancerous glands, presence of cancerous glands. Similarly, there is an elevated type 2A lesion in the body of stomach on the greater curvature. On NBA, it is densely packed. Regular pattern which is of densely packed. On histology, which shows adenoma. Similarly, there is an erythematous lesion in the posterior wall of upper gastric body. This erythematous lesion on NBA showed irregular microvessels and irregular mucosal surface. On histology, it confirmed as well-differentiated adenocarcinoma. Similarly, this is a benign-looking gastric cancer. On NBA, this cancer has absent microsurface pattern and irregular microvasculature. On histology, it confirmed as poorly differentiated adenocarcinoma. Similarly, there is an ulcerative lesion in the gastric antrum where the walls are protruded. On NBA, it showed irregularly microvascular pattern. There is difference in shape, microvessels are different in shape, different architecture, and the tortuousness is increased and heterogeneity is changed. On endoscopy, it confirmed as moderately differentiated tubular adenocarcinoma. So these are the lesions. By seeing the NBA pattern, you can differentiate between, we can say whether the patient is having abnormality or not. Coming to the colonic lesions, there are different pattern recognition societies. One is Kudos Pitt pattern, NICE classification, and WASP classification. Even Japanese classification known as JNET classification. This JNET, routinely we use NICE or JNET classification. This JNET classification also will say, based upon the microsurface details and the microvascular details, if there is regular arrangement of the surface and regular arrangement of the vessel, it is nothing but a hyperplastic polyp or a sessile sedated polyp. That is type 1. If there is a regular arrangement of the vessel, but the surface pattern is tubular or branch, it is type 2A. It indicates low-grade neoplasia. If the vessel pattern is irregular and the surface pattern is irregular, we can label it as high-grade intramucosal neoplasia. If the vessel pattern is loose and the surface pattern is amorphous, we can say there is a deep submucosal invasion. So see the image. This is a polyp, subcentimetric polyp found in the rectosigmoid lesion. You check whether you see the NBA pattern of this lesion. The surrounding mucosa is regular. Even the polyp is also regular, which looks like the surrounding mucosa, and the vascular pattern is also normal. This can be a hyperplastic or sessile sedated polyp. On histopathology, it identifies as a hyperplastic polyp. Next, coming to the This is also a polypoidal lesion in the rectosigmoid lesion. On NBA, the mucosal surface pattern is tubular and the vascular pattern is regular. It is type 2A. So it can be an adenoma, it can be a low-grade intraepithelial lesion. So on histopathology, it shows high-grade tubular adenoma. Coming to the slightly elevated lesion in the colon, that is descending colon, on NBA, it showed irregular distribution of microsurface and irregular distribution of vessel wall. On NBA, we can identify this is a high-grade intraepithelial intramucosal lesion or a shallow submucosal invasive cancer. On histopathology, we can say it is an intramucosal carcinoma. Similarly, there is a polypoidal, sessile polypoidal lesion in the descending colon. On histopathology, there is an amorphous layer. Amorphous layer will indicate there is a deep submucosal invasion. So this can be confirmed on histopathology. That is nothing but a deep submucosal invasive cancer. So finally, even the subtle lesions can be identified by using the chrome endoscopic technique, either by dye-based or digital chrome endoscopic technique, which can predict there is an abnormality in the lesion, which guides the endoscopist to take the biopsy from the lesion, which guides the endoscopic to say whether the patient is having dysplasia or invasiveness. It has to be confirmed finally by the pathologist. It is a teamwork we have to do. Thank you. Yes, sir. No, sir. Before only we will do. Yes, sir. No, sir. Before only we will confirm, we will see. Then we will go for an EST or EMR based upon the discussion.
Any questions from PGs?
Thank you, sir, for the insightful and enlightening session. We request you to kindly stay back on the dais for a moment, sir.
We now invite Dr. PJ Naidu, sir, our respected HOD, sir, and other dignitaries to please come forward and present a memento to the guest speaker.
Moving towards the inauguration of today's CME program,
As we commence the inaugural ceremony, we invite Himashi and group of 2024 batch for the prayer song.
we also invite the dignitaries to grace.
Moving on towards the next session,
The session is on approach to non-neoplastic colorectal lesions.
this will be delivered by our distinguished guest, Dr. I. Satish Rao, sir, MD Pathology, Senior Consultant Pathologist, Lead Histopathology and Cytopathology Division, KIMS Secunderabad.
We invite Dr. B. Gautami ma'am, Associate Professor, Department of Pathology, Jensen Hospital, to kindly come forward and formally introduce our distinguished guest speaker to the audience.
It is an honor to introduce our distinguished speaker for today's CME. Dr. I. Satish Rao sir is a senior consultant pathologist and currently working as the lead histopathology and cytopathology division at KIMS Secunderabad. He had 25 years of post-MD experience in the fields of oncopathology and immunohistochemistry. He completed his MD and senior residency from the prestigious All India Institute of Medical Sciences, AIMS, New Delhi, and he has worked as an assistant professor at Nizam's Institute of Medical Sciences, Hyderabad. Sir had gained international exposure having worked as an observer in immunohistochemistry at the Miller School of Medicine, Jackson Memorial Hospital, Miami, USA, and as an observer of liver transplant pathology at Queen Elizabeth Hospital, Birmingham, UK. His areas of special interest include bone and soft tissue pathology, gastrointestinal pathology, lymph node and dermatopathology, as well as native and transplant pathology of liver, lung, and heart. Sir had made significant academic contributions with 53 publications as an author, with a co-author in national and international journals, and as a reviewer for national journals. We extend our heartfelt gratitude to our guest speaker for sparing his valuable time, and we are indeed privileged to have him with us today and look forward to an enriching and informative CME session. Now, I kindly invite Dr. I. Satish Rao sir to kindly take over the session. Thanking you, sir.
Thank you. Thank you. I'll use my. So, good morning, everyone. Everybody is sleeping? You had your breakfast? Yeah. Thank you to Naidu sir and the rest of the faculty for giving me an opportunity to speak here. I really find this hospital very good. It has got that medical college feeling. So this is nothing to bore you or just confuse you or anything. How many of your PG students here? Rest all are MBBS? Huh? Why are the PG students sitting behind? Come to the front. Come to the front, please. Because this is going to be an interactive session. And I will not be your examiner anyway. Please come. See, this is just a comedy. Basically, I'm trying to put some comedy here. There's nothing, sit and taking no notes, nothing. Just be interactive, be relaxed. I don't think Naidu sir will be your examiner also. So don't worry about it. Just come to the front. If you want to be a little serious about it, then please come to the front. Arey, third, come to the front. No issues. Come to the front. Why that lady is sleeping there? Second. Madam, mere pink dress. Mundu grand. All the PG students, please come to the front. Be interactive. Please don't mind. This is just an interactive session, so I want residents to be sitting in the front. Okay? So you have to give me 1 hour. Sir, 1 hour, sir. Right. How many of you smoke cigarettes? Yeah. Those who smoke will understand. This is the colonic pathology. If you see, this is colon is affected by everything. You eat everything, you drugs, anything you take, it will affect the colon. So colon, and once you have a GI disturbance, it's hell. You cannot concentrate on your work, right? So those who smoke cigarettes, there is some protection from inflammatory bowel disease, but don't smoke for that. Okay, it's better to take medications but not smoke. So if I have put these cigarettes here, are you able to see this arrow there? Yeah. Just a minute. So if you see this, how the cigarettes are arranged in this packet, that's how the crypts are arranged. So if you see the crypts from the top, you may see like this. So if when the arrangement is correct, you know that the architecture is maintained from the top. So if you free from the sides on a longitudinal section, they're like test tubes. So if you understand here, they're arranged with some space in between and resting on a muscularis mucosa. So something like this. So this is a typical histopathology biopsy of this. Okay. And you don't have much cells there. You don't have some scattered inflammatory cells, some lymphocyte, on occasional eosinophil, mast cells, and all those. What is missing is neutrophils, right? So now even the faculty also can answer this, or the PG students who are a little more senior. Can you guess the site of biopsies? Interactive. The more you delay, the more it will delay. I will not move from the stage. Inauguration will get delayed. Can you guess the sites? What is this site? What is this site? What is this site? What is this site? Colon. All are colon, right? Which part of colon? What is this? This is right. This is left. This is cecum and anorectal junction. So what happens is there are some rules where the inflammatory cells, how they are distributed, you should know. So that's the gastroenterologist should say. If the gastroenterologist says colonic biopsy, it doesn't make sense. They have to specify from where. Are they giving from colon, right side colon, from the left colon, from the anorectal junction, or from the cecum? So then you will know, okay, this is the normal variation which I should not interpret as a disease. So you should know this. So this is the left colon where you have plasma cells commonly on the top but not below. But here if you see right colon, you have eosinophils and plasma cells everywhere. You have a cecum, you have a lymphoid nodule there. So that is not abnormal. You take it as normal. And this is anorectal junction. You may see the crypt atrophy or some disarray is there, right? So now if you see this is normal variations, you should first be aware of normal variation. How many lymphocytes can be seen in surface epithelium? 5 per 100 surface epithelial cells. It's almost the same as in small intestine. On the lymphoid nodules, it will be more, and on the right-hand side, it will be more. Similarly, transmucosal lymphoid nodules, 1 per biopsy piece. Suppose they have got 5 pieces, 5 fragments, 1 per biopsy piece is normal. If you see 2, 3, 4, 5, then something is going wrong. You cannot say it as normal. Distorted architecture. Near the lymphoid nodule, from 3 crypts near the lymphoid nodule, it is normal, or near the anorectal junction. So after 3 crypts from the lymphoid nodule, you see there is a distortion, something is abnormal. Similarly, neutrophils. More than 3 neutrophils in lamina propria is abnormal. And plasma cells. This is always a gradient. I'll show you a picture. Always a gradient that on the top, you will see plasma cells normally. And as you come down, the plasma cells will be lost. They'll be decreased. It will be absent, but this gradient is lost in cecum and ascending colon. Similarly, eosinophils, 20 per hyperfilled is taken as normal. It is normally more in the right side. If it is on the left side, there are more, then it's abnormal. Then subepithelial collagen, 4 to 5 micron thickness. Apoptosis less than 1 per crypt. And muciphages. So I'm also given the reference. Suppose you're not able to note down, at least you know the reference. You go and read, will understand. Right. So now this is how, if once you see the neutrophils, what is your commonest diagnosis? Infection? Yes. So see, this is how I found this is a good book actually. These pictures are there. I've taken out from this, not mine. I've copied it. Okay. But I thought it will represent. So the biopsies, when you see from the side or from the top, you are able to make out there's a distance between the crypts and there's no atrophy or no branching. So this is what I am talking of the gradient. See, if you see half of the, if you draw a line, you see plasma cells here and below. So once the plasma cells come down, then it is abnormal. So the definition of abnormalities now we should note. Now we are told you the normal variation. Now you should know the definition of the abnormal thing. What is basal plasmacytosis? If you see plasma cells adjacent to the crypts, base or between the crypt base and muscularis mucosa, then that is basal plasmacytosis. What is crypt distortion? Any change in the shape, size, variation, size, branching, loss of parallelism, irregularity, tortuosity, dilatation, everything. That is crypt distortion. So you don't have to write in your report. If you observe, you say it's a crypt distortion, it's fine. Crypt branching is also a kind of distortion where 2 or more bifurcated crypts are there, branching. What is atrophy? More than 1 crypt diameter space between crypts or between the crypt base and muscularis mucosa. As I told you, it is normal near the anorectal junction. Then Paneth cell metaplasia, it is normal up to splenic fracture. Any biopsy after splenic fracture, it is abnormal. And granulomas, there is no limit per se, but there are you words use microgranuloma and granuloma, large granulomas. At least 5 epithelial cells are enough, not to be confused with the general center. So this is how I show you. If you see here, the lymphoid nodules are increased, it's abnormal. You can see on the cross section like this. And if you see the plasma cells have come down between the crypts or below the crypts, it's abnormal, basal plasmacytosis. Now with neutrophils, now with abscess formation, all this is abnormal. Now this is crypt. You can see the size variation is there. This is abnormal. That is the branching. You see, when you see this kind of dividing crypts there, this is branching. If this is irregular shapes, all these are crypt distortion. This is atrophy. Between the crypts, more than 1 crypt diameter, between the crypts or between the crypts and the muscularis mucosa. Granulomas. These are, if they are close to the crypts, they are cryptolytic granulomas. These are the, what we call it as sarcoid-like or Crohn's-like granulomas when their crypts are not getting destroyed. You can see, as I told you, you can confuse these granulomas with something else, with a blood vessel or a lymphoid nodule or a fibroblastic. So you see this, follow this section. As you cut deeper cuts, this becomes a crypt. So you can confuse this also as a tangential cuts. So this you should understand. How many of you give this diagnosis of non-specific colitis? Stop, avoid that word, okay? Because the gastroenterologist will look at you like this, and the patient also will look at the gastroenterologist like this. I have spent so much money, so much loose motions, preparation, and then suddenly you say non-specific. Then why did you do the scopy findings? Okay, so at least say histologically unremarkable. Non-specific word, don't use the word. The textbooks say don't use the word. Okay, some classifications they give non-specific, but so the simplest word is bowel preparation artifact. Okay, so this, if you suppose at least say this is histologically unremarkable, could be secondary to bowel preparation, rule out resolving infective colitis, rule out drug-related etiology. You are right. Don't say non-specific. Negative for granulomas parasite. Maintain plasma cell gradient. At least write your observations. The gastroenterologist says, okay, boss, he has gone through the checklist. So write like that. Okay. So now if you see here, this bowel preparation artifact can cause a lot of increased apoptosis in the crypt epithelium. not in the crypts, but in the crypt epithelium here on the top you can have, and you can, there will be mucin depletion, you can have a flat surface, or you have lamina propria, lysed blood cells, anything. So the differential diagnosis would be, so as I said, no, instead of giving non-specific, at least you say could be secondary to bowel preparation, resolving infective colitis. See, many of the patients lose motions, they would have taken some antibiotics already. So you just see the duration, how much time it has been taken. Now, you can see the big list of differential diagnosis, which I'm not going to cover everything here. This itself is a big topic. So at least remember transplant. You have a bone marrow transplant done, you have a graft versus host disease, may look absolutely normal. Don't give it. If you have the transplant setting, you have to really take an opinion from somebody or read or take multiple depositions. This is what I want to tell you. So now here, how many of you think pathology is a paraclinical subject? Stop thinking about it now. Okay, if you go to US, it's a physician, it's a clinical branch. In US they say it's a clinical branch. So here, if some of your PG students, especially for PG students, somebody says, why do you need history? Because it's a clinical branch. I need history to interpret. Okay, so what are the history you require? Age, gender, diarrhea, clinical history, radiological findings, travel. All of us from Andhra and Telangana, at least one relative will be in US. And all of us will go visit and eat something, breathe something and come back. We carry something from there. So travel history is very important in GI and pulmonary pathology. Travel history is very important. Then any cancer treatment, because a lot of drugs are being given these days, which can cause a lot of diarrhea related, most common symptom would be diarrhea. Then you have family history and everything else, right? Even stool culture is also important here. Okay, so now if you look at this chart, if you see the inflammation, when you get a biopsy, see after the history you have got, you see the inflammation. What is there any eosinophilic infiltrate is there or not? If you see a lot of eosinophils, there is allergic or eosinophilic gastroenteritis, mastitis, IBD, drugs, and so on. Then you look at if there is any acute inflammation of neutrophils is there, and there is any ischemic change or any hemorrhagic change. If yes, then your DDs would be ischemia, radiotherapy, infections, IBD, drugs. Don't take photographs. Full picture will come, then you take a photograph. Yeah. Then try to understand. So then if there's no ischemic or hemorrhagic, then think of infection, drugs, IBD. If there is a chronic inflammation, look at the architecture. If the architecture is distorted, then you suspect IBD, diverticular, diversion, drugs, and so on. If the architecture is preserved, then you think of microscopic colitis, early IBD, resolving IBD, drugs, diverticular, and so on. If it is post-inflammatory, no inflammation is there, then look for apoptosis, drugs. So what is common here? Now you can take photograph. So what is common here? Drugs. Okay, so if you see here, everything moves up and down based on what predominant picture you have got. The gastroenterologist should be your close friend. They should not criticize you first, number one. Okay, so then once you know, okay, I'm seeing this kind of picture, tell your findings. These are the main picture is this much. This could be, these are the reasons, these are the differential diagnosis. You exclude one by one. Then they will correlate automatically. So you can use these words, focal active colitis, acute colitis, or chronic colitis, where when you're not seeing any chronicity features. I'll tell you the chronicity features also. When you start seeing chronicity features, then you suspect other conditions, IBD and all those things. So you can use this, this is a good article has been given, you can take it this, where you can say just classify the colitis acute or chronic, it is active or inactive, then it is mild if it is less than 50% of crypts, moderate more than 50%, erosion ulcer, severe. So depending on the gastroenterologist terminology, how they are going to treat, many gastroenterologists will have a specific words. So you can also use this word focal active, diffuse active, focal active chronic, or diffuse active pneumonitis. So they will tell you that, okay, it's a chronic condition, but some activity is going on. So it should be a clinico-pathological correlation. You should get your terminology right with your gastroenterologist. So eosinophilic colitis, I'm not going to cover much actually in this, but if you understand, you see lot of eosinophils. I told you on which side of the colon eosinophils will be more normally, right side. If you're finding too many eosinophils on the left side, something is abnormal. So what is the cutoff point? What is the cutoff point? So if some people use normally more than 35 is taken as abnormal, but it's not like it's a more of a clinical basically. If you're seeing a lot of eosinophils within the epithelium, microabscess formation, muscularis mucosa infiltration, all these features may tell you that you are dealing with some eosinophilic enterocolitis, then the clinico-pathological correlation will come. But meanwhile, you should rule out allergy, mastocytosis, infection, IBD, and all those things. Infective colitis is the most common. Okay, I told you what you are supposed to remember is a plasma cell gradient. So once you get the biopsies from left side of colon, just look at the plasma cell gradient. If the gradient is maintained, the plasma cells are on the top, then you look for other things. So if you see there's an ulceration of epidermis, you're able to see the. Why it is not out of focus here? Why it looks out of focus? Can you sharpen it a bit? Because I am seeing it very clear. I think here it is a little hazy. Okay, ma'am. Sorry. So now if you see here, if you see this, there's an ulceration, the mucosal surface is lost, the plasma cell gradient is maintained, and the crypt architecture is maintained. Look at this and say, okay, this could be infective. Once you start seeing basal plasmacytosis, architectural distortion, and pyloric metaplasia, you start suspecting an inflammatory bowel disease. So which one is IBD and which one is infection here? Which is an infection? Which one is IBD? On your right side, IBD. I can close my session actually. Done. Enough. So if you see here, so you can safely say, okay, this could be this thing, like, right? So so there are mimics of IBDs. You know, Crohn's disease. There are infection which can mimic. You have ulcerative colitis which can be mimicked by Shigella and enterohemorrhagic E. coli, and ischemic colitis also. All these can confuse you with this thing. So again, here comes the stool culture, duration, everything else. If you see, this is the pattern. You can see you have a microvascular thrombi. You can call it as ischemic. Pseudomembranous changes, you can have it here. You can have it this hemorrhagic pattern, and this is a ischemic pattern. You have a stromal fibrosis like pattern. So you may wrongly label it as ischemic, but it may be infective. So you should correlate clinically. Now this is an ischemic colitis. You see here, the crypts are bursting out. You have some exudate and a lot of thrombosis. The clinical picture is very important here. So what is this? Some exudate is there on the top, right? Higher power. Still higher power. Amoeba. This you cannot miss. Okay. All these are amoeba. Either eating the RBCs. Okay. So whenever you see some exudate on the ulcerated surface, you have to search for amoeba. Okay. Because it will have all that ulceration, inflammation, everything will be there. If you have history of Pani Puri, 100%. Take it. Okay. So this is amoeba is one thing which you cannot miss. Actually, it's so easy treatment, you cannot miss. You should make a checkpoint of amoeba at least. So you should always write negative for granulomas or parasites. You have the last point you write, it's fine. Okay. Now this is a typical picture of so much exudates. Both are different etiology, but they are different. So this is one. is pseudomembrane, which is diffuse, and there is focal. Okay, so this is ischemic, this one is ischemic, and this one is infective. So this is how the exudate will come. You look at the scopy picture, it looks like as if you are on the flying on an aircraft and then looking at a volcano like this, right? Something like that. So you'll have a typical volcano-like exudate. If you have a volcano-like exudate, you are probably dealing with a pseudomembranous colitis, right? So if you look at a higher power, the crypts. So what is peculiar is the exudate is adherent to the mucosa. Once it is adherent to the mucosa, you start suspecting could be it is a pseudomembranous colitis. And when you see this, still you search for amoeba first. No amoeba there, then you start suspecting, oh, this volcanic like eruption is there. So probably I'm dealing with this thing. If you see here, there's a lot of infections can also cause. That's why stool culture is again required. You'll ask for stool culture, you say pseudomembranous colitis correlated with stool culture. Even acute ischemia can cause, and acute RT can cause. So many drugs can cause. If you see cisplatin, cyclosporin, then 5-fluorouracil, NSAIDs, paraquat, all these can cause. So now, running man. So now you have this is a typical volcano you are seeing here. Once you see this volcano, you're probably dealing with this thing. So you have 3 patterns, which I'm going to skip. What is this? Clinical scopy picture. It is a cat scratch colon, as if the cat has scratched the colon. You have 2 cats in GI tract pathology. One is cat scratch colon, another is feline esophagus. Have you heard of it? Feline esophagus or cat? It looks like cat's trachea. It is known as feline esophagus. That is, once they say it is, so that is in eosinophilic esophagitis, you will have feline esophagus. You will have almost trichalization of esophagus, they say. And here is a cat scratch colon. What I'm talking of is collagenous colitis. So here, what will be the typical history? Watery diarrhea. You'll have watery diarrhea, women with watery diarrhea, with some autoimmune disorder, which is pretty common in females. And for that, they will be taking a lot of NSAIDs also. And loose diarrhea, watery diarrhea, scopy, normal, right? Then you have, that is what is collagenous colitis. Because of the collagen, sometimes there will be mucosal tears that leads to cat scratch colon. It can be also seen in ischemia, diverticular disease. So the base collagen band thickening is just not the diagnosis. You should have watery diarrhea and all those pictures. You'll have some inflammation, and you have vessels entrapment by the collagen. This you will call it as collagenous colitis. So there's different variants of there. I'm not going to cover. Brain will burn. So I'm not going to cover. I'm just put it there for the namesake. But if you're able to identify at least 2 types of microscopic colitis, means microscopy means on scopy there is no colitis, but on biopsy you're able to find there is thickened collagen entrapping the blood vessels like dripping wax. So what you'd understand is, I told you the thickness of the basal membrane. Basal membrane thickness is 5 microns. If you see 10 microns, means more than a lymphocyte or an RBC, it's probably thickened. You can use a special stain and then call it as, and they should also try to, they will be entrapping the blood vessels also. That is the clue that you are dealing with collagenous colitis. Another one is lymphocytic colitis. I told you lymphocytic colitis, where it is taken as normal, near the right side colon and all those things normal. So if you see on the transverse colon and everywhere, you take it as, okay, maybe it is a lymphocytic colitis. So then more than 20 intraepithelial lymphocytes, you take it as lymphocytic colitis. This is also a kind of microscopic colitis. What is the diagnosis of this? So I'll give you the clinical history, probably you diagnose this. Anybody thinking of a polyp here? How many of you think of a polyp here? Polyp? Polyp? Yes, right. Whoever is lifting the one, just one pen she is raising, one girl. like this, half-heartedly. You're right, it's a polypoid. This thing is okay, it's fine. I'll tell you the history. There's an ulcer in the rectum, and there's a history of digital evacuation of stool. Now, what's your diagnosis? It's very simple. The patient will come, the gastroenterologist will say there's an ulcer in the rectum, history of digital evacuation of stool is not coming out normally, and there's an ulcer. What will be the diagnosis? This is a polypoid lesion, may or may not be there, but what you will find is fibroplasia of the lamina propria, and muscle fibers will go in between the crypts. Straightforward diagnosis. This is nothing but solitary rectal ulcer. So you should not call, you can have atypia, you can have a pseudomembrane, but don't call this as malignancy or dysplasia. ఎక్కడో anorectumలో అక్కడ ఉంటే దానికి డిస్ప్లేస్ అంత ఈజీగా అనకూడదు. You should see the clinical picture. So if you see this fibroplasia and this stellate crypts, you may be tempted to call it as a polyp. But don't call it, you see what is the clinical picture. There's an ulcer, digital evacuation, call it as this thing. This fibrosis of lamina propria is one important feature, and you see muscle fibers going in between the crypts. The musculus propria will also be thickened. Okay. So whoever was asleep, now I'm going to check who was sleeping. So now you wake up and let me see if you are awake or not. In the first part of it, this is the second part I'm coming now. So now you look at the mucosal chronicity changes. Once I told you the activity, right? Abscesses, cryptitis, necrosis, regenerative epithelial changes, erosions, and all this are all activity. But you look at the chronicity changes. So you have to look at the mucosa. It becomes irregular or filiform. You have crypts. I told you all the crypts, shortening, irregular spacing, irregular shape, branching, epithelium, pyloric metaplasia or panesal metaplasia or panesal hyperplasia, lamina propria, basal plasmatosis, lymphoid aggregates, mixed inflammation, submucosal fibrosis, muscularis mucosa thickening, and all these are chronicity changes. Something is long standing. So I'm not going to ask the questions. I just want you to remember this. I told you, whoever has taken the photographs earlier, no need to take again. Those who have not taken, you can take it now. So these are the chronicity features, the definition what you have. So please try to look at the any colonic biopsy history and chronicity features. So I'm not going to tell you this whole thing, but it's a good article. You can go to this article I already told you, where they told you how to distinguish between. So once you see chronicity features, you are towards IBD. You are not seeing much of chronicity features, you are towards infective. If you're seeing a lot of granulomas and chronicity features, more like Crohn's disease, like that. So these are what picture is. This is an aphthous ulcer. You have an exudate, you have an ulceration over the follicle and there's an exudate there, or you have a fissuring ulcers, or you have a pyloric metaplasia. So this is the, if you see pyloric metaplasia, it's definitely abnormal. There's no doubt about it. You should not see in the colonic biopsies. If you're seeing it, that means you are dealing with some chronic conditions. So this is all the typical features of active chronic inflammation, mucosal inflammation, panesal metaplasia. This is how you see, this is the muscularized mucosa. You see here, these crypts are looking elongated because of edema and lot of abscess formation, and the inflammation is also going into submucosa. You see in the higher power, like this. You see, I told you how many lymphoid nodules are acceptable per piece? 1 per piece. But in one piece, you are seeing 1, 2, 3, 4, 5, 6. This is, don't take it this as normal. This is something abnormal. This should on low power itself to tell you, okay, I'm dealing with something IBD. And you look at carefully, there is a crypt branching, crypt loss, and this mucosal membrane thickening, muscularis mucosa thickening. There's loss of goblet cells, cryptitis, crypt abscess, everything is there. So what I'm going to tell you here is, to the gastroenterologist also, or in the pathologist also, sometimes when in early IBD, you may not find all the features. So you should look at the timeline. It may take 1 month for IBD features to develop, and it gets established by 4 months. You look at this here, the crypt distortion, everything starts by almost like it takes almost 1 month to start. So in the early initial phases, you may not find the chronicity features. So you may ask the patient, you can ask the gastroenterologist that you treat with antibiotics, still is persisting, then come back with the colonoscopic findings, again a repeat biopsy. Or if looking at plasma cells below, highlight that something is abnormal. I'm looking of an early IBD. So I'm sorry, this focus is out. There are scoring systems are there. It's very difficult to do this scoring actually. I get bored. But what I do is, the simplest scoring is, this is one article has come 2021. This you can take a Virtuous Archives, you can download this. This is IBD DCS score, very simple. Just look at the distribution, normal, less than 50% per same biopsy site, more than or equal to 50% per biopsy site. That is D1, D2. Similarly, chronicity features, normal, crypt distortion, marked lymphoblast like 1 and 2, and activity features. So very simple. I don't use my brain. I just say IBD DCS score D2 C2 A2 or D1 C2 A1, like that. So I'm not going to explain this. This is you can go and read it, because I put in this short span of time I cannot explain, but you can download this article and read it. Now see here. What is this? 47-year-old male ulcerative colitis on treatment, and there's a friability and ulceration. Anybody? Some abnormalities being seen. There is some crypt loss also. On higher power. So remember, ulcerative colitis will be complicated by CMV inclusion, CMV infection always. Sometimes it may precipitate. So the gastroenterologist will ask for this, please look for CMV virus. Without that also, you can see your known case of ulcerative colitis now presenting with a sudden episode, look for CMV. Right? Next point, unusual presentation of ulcerative colitis. You can have rectal sparing. You see, rectum is classically involved in an ulcerative colitis, but it may be spared in pediatrics. In children, you may, in a pediatric age group, you may not find the rectal involvement, or it is a burnt out ulcerative colitis, or when some patient will take steroid enema. So the rectum will be cured, but the rest of the thing will be still persisting. Then skip lesions. You can have appendix orifix or upper GI involvement. Ileitis, you can have a backwash ileitis, or you can have cryptolytic granulomas. So this is one of our resident actually, Nehal Rahate. You can actually follow her. She is artist by profession. She is a pathologist, artifying pathology on Facebook. She has got more than 2,000 followers. So all the pathology, she will put it as a picture. That's what she does. So she has divided this inflammatory bowel disease like ulcerative colitis and Crohn's disease. You can just go and see. It's a Facebook. All of you must be on Facebook. If you're not on Facebook, something is wrong. Yeah. So now what are the mimics of IBD? If you have close mimics are diverticular colitis, and so diversion. So here the gastroenterologist should tell. Here there are some diverticulae. Those should not be called as IBDs, because wherever there is a diverticulum, the picture will be exactly like IBD. So diverticulum or diversion proctocolitis means they have done some anastomosis here and there. That will also look like IBD. So this should not be called as IBD. You should be careful in mind. Diverticular colitis and diversion colitis should not be called. So this is the diverticula. I'm not going to explain. Please read it. This is all diverticular inflammation. This is again diversion colitis. You have lymphoid follicles with almost like an IBD picture. Don't call this as an IBD. You should ask the history. Any surgery has been done, any diversion has been done. Now ischemic. You can see the early ischemia can look like this: crypt loss, hemorrhage, and all these things. And sometimes they burst. The crypts can burst and they form pseudo-signet ring cells. This you should not call it as carcinoma, because you may have ulceration and all those, and you see these pseudo-signet ring cells and say it's a carcinoma, gone case. They'll remove and give it to you, the patient will out. So here you should be very, very careful. So this is just a picture of how a chronic ischemia of the intestine looks like. This is the small intestine, almost like Crohn's disease. You have these crypts, you have this fissuring ulcers and atrophy and everything. Now the most difficult is pauci-inflammatory. These are the cases where you will call it as non-specific colitis, which you should not give. This is 47-year male rheumatoid arthritis with diarrhea, ulcer. They're suspecting rheumatoid arthritis, now driving diarrhea and ulcer. What is this? Is it Crohn's? No, it's not Crohn's. It is drug-induced apoptosis. These are all apoptotic colopathy. So you take the drug history and say this could be more like not Crohn's. It is more of a apoptotic colopathy. Now, this is very important. Any patients of Fanconi's anemia with Clostridium difficile infection diarrhea, granular mucosa, and loss of vascular pattern. What is your diagnosis here? Low power diagnosis here. What is your observing here? There are lots of crypts. The crypts are lost, right? That definitely it's abnormal. This is not Clostridium difficile. Where is the pseudomembrane? Where is the volcano? Not there, right? So you should look closely. Again, there is apoptosis. This is also all these are apoptosis there, and there are apoptotic abscesses are being formed. See this? This is the apoptosis. All these are apoptosis going on. This is apoptosis. See here, this is a crypt loss is there. You see, there's a patch of crypt loss is there. So this is you can see this picture. This is cryptosis. You not have more than one undakodu. Ante one crypt lo more than one code undakodu. You should not be able to find. You're finding me something is abnormal. So this is actually what? This is graft versus host disease. The patient will be very bad. He'll do very bad. You just say non-specific means gone case. Patient will die. This is gone. Now to complicate a little more further, you have graft versus host disease. And these transplant patients are also on mycophenolate drug, which can also cause similar features. And mycophenolate also predisposed to CMV. Triple whammy, right? You have graft versus host disease can occur in a transplant patient. They are on MMF, then MMF predisposed to CMV. So you should be very, very careful. As a post-transplant means you don't know, don't report. Take an opinion. So here, how do you see? In MMF, drug-induced colitis, you'll have less lymphocytes and crypt apoptosis and more of eosinophils. If you see a lot of eosinophils, you can say probably more like MMF. And look for CMV. If you're in doubt, do a CMV IHC and say CMV is negative or CMV serology. So it's almost over. 5-10 more minutes. So just wanted to understand that this chart, you should keep it in mind wherever it is possible. There's so many drugs which is impossible to remember also. Keep impossible to remember. Just say, okay, drug can come everywhere. So NSAIDs can cause this similar, almost like inflammation, IBDs, you have ulcers. And these days you give a lot of drugs, immunotherapy drugs is being given. So all these drugs can cause similar kind of picture. So I'm not going to cover everything. Now I am discussing only 4 cases where it was very difficult. These are the ones to understand how things change. 5-10 more minutes, madam. Sir, 5-10 more minutes I have. 5 minutes, yeah. You see the case 1, this is 35-year female. I told you the patterns, right? What is the first pattern telling you? Some abscess is there. So, what? Focal, diffuse, what you will call? Focal active colitis, right? Some inflammation, pericryptal inflammation is there. What is happening here? Can somebody diagnosis? Apoptosis and something here. Cryptosporidium. You have this cryptosporidium fungal infection. So you have to really look very closely. You cannot pass it on as non-specific. Nothing doing. Not acceptable. So you have to say focal active colitis with apoptotic colopathy. Maybe the patient is on HIV drugs. Plus there is also there are 3 pathology in this. So you have to tell all 3 pathologies. There is some focal active colitis, treat infection, what you think, or resolving infection. 2, you have to give cryptosporidium. 3, you have to see apoptotic colitis because of drug induced. You see the drugs, what is being caused. This is a recent case actually. 22-year female, from USA, SLE on azathioprine and steroids, query infection with Crohn's, and biopsy was done. So as usual, second opinion, third opinion, fourth opinion. Everybody will go for it. So you have to be very careful in writing the report. How do you write it? So there is an ulceration. See this The mucosa is completely ripped off. So clinically they are suspecting infection. But are you able to see something else? Granulomas, right? So now you use your common sense clinically. The patient on SLE is being azathioprine. Azathioprine is also given for Crohn's, right? So if some Crohn's is, they should have resolved also. Why it is coming as this thing? So we told no, this is not looking like Crohn's. It is more like a infective pathology with probably TB. If you rule out TB, then you consider as SLE with infection with Crohn's. So now the patient is undergoing CT scan, everything. So first our infection is controlled now. After infection control, they'll do again a scopy and see what are the other organs are involved. So one clue I want to give when to suspect TB at Crohn's. Everywhere in the body you can follow it. What happens is the granulomas which are formed in the TB, they will all come together. What we call it as confluence or coalescence, and the mucosa over it will become necrotic. It falls off. So if you are seeing granulomas in an ulcerated surface, more like TB. If you're seeing granulomas in non-ulcerated surface, more like Crohn's. Yeah, this is one case. I think those who are feeling little sleepy, please wake up. This is one case which really taught me a lot of lessons. See the history. This is a 16-year female. Okay, she has history 2008, 16-year female with fever, abdominal adenopathy, and pain for 2 weeks. She had watery diarrhea and melena since 16 days. CT enteroclysis, IC valve and terminal enhancement, and thickened mesenteric and paraaortic non-necrotic adenopathy. CT chest unremarkable. Terminal ileal biopsy and cecal duodenal biopsy. So still the history goes still further. She had 2 weeks of pain abdomen 2003, palpable purpura, query HSP, and family history of TB, has a pet dog. Too many history is there. Mother is also a doctor. So there's a bigger history. Okay. So what do you see here? Some inflammation, right? And what is the villi are kind of little thickened, right? So what is the diagnosis here? So this was called as Crohn's in the first time. And what are you seeing here? Anybody? Granulomas? It's okay. Clue is granulomas. How many granulomas are here? All those are granulomas. So there are micro, macro, confluence, non-necrotizing granulomas. So when they came to me, I told it is TB. So remember 2003, 2008, 2009, I told it is TB. Please take medications. So, but here, why I suspected, because the ileal biopsy looks normal. In a Crohn's disease, remember, Beemudu gadalaga untadantar. All of you understand Telugu? The villi will engorge. They become like just like this. The villus tip will become engorged like this. If it is there, then you suspect it probably is suspecting Crohn's disease. So here the villi are looking absolutely normal. These are all soft clues basically. Okay. So to complicate further, the gastroenterologist did some more tests because the patient has a dog. Okay. The patient has a dog and brucella was done, it was positive. The patient was put on some drugs, LFTs, and patient was treated for brucellosis. So in 2008, she was given some drugs, rifampicin was given for 2 months, patient improved. So they said, okay, diagnosis is done, it is brucellosis. Over a period of time, she started having weight gain, irregular periods, and PCOD symptoms. And the gynecologist started, because she was a gynecologist, PCOD, she started treatment for PCOD. So in 2013, she has again abdominal distension, stretching pain, low grade fever, MAN2 positive, Again, they came. See, the villi are still normal, right? The villi are looking normal. And you can see some granulomas here. So she had evening rise of temperature, weight loss for 4 kgs, came back to India. Then this time I put my foot down and told the gynecologist, nothing doing, this is TB, I'm telling you, start treatment. So she started treatment, and as a magic, her PCOD disappeared. She had normal periods again. So it was magic. So in 2014, she had again bleeding PR, again back to India on ATT since 7 months, again nodes. These are all she has all these granulomas again. Finally, I still said it is TB and nothing but TB. We stuck to TB. And just for the gastroenterologist did one AFB stain, and AFB was positive in this. Just on the biopsy, make a splash smear, did an AFB, it was positive. Then I said, see, it is again TB only, nothing but. So now it is 2025, normal with ATT. So if you would have started Crohn's disease, catastrophe, right? So till now, that gynecologist is in touch with me. Okay, this is another case. This is another patient from US. I'm not telling that something great, but this is something we have put it together over a period of 10-15 years follow-up low. This is case number 4. This is the last case, and I close my PPT of this. This 15-year male presented with 2015. This is again a patient from USA with lower abdominal pain, persistent 4 months post appendicectomy, past history 2011 giardiasis in US, and appendix was removed in Hyderabad, sent to some diagnostic lab, and as usual, appendicitis. Okay. Now, to complicate further, he had a dilated colon, suspected Hirschsprung disease, severe pain during defecation, chronic constipation, fissures, not gaining weight. He had also upper GI symptoms, reflux disease, and gastric biopsy was done. Anything abnormality you are able to find? Nothing, no? So I said nothing. The gastroenterologist told, no, he has got symptoms. You do something for this. What I have done is deep cuts. Are you able to see the size of tissue is increasing? Right? So here, that when you do this, the technician will curse you. Nothing doing. If it is not matching with my clinical picture, I will take deep cuts. So you saw this iceberg. The biopsy is like an iceberg. And you know what happened with Titanic. So whenever the clinical picture is like Crohn's, or the gastroenterologist is suspecting and he or she believes you, then do a deep cut. That's all. Let the technician curse you. No issues, no problem. Are you able to see any pathology now here? So we found some microgranulomas here. See, this is microgranuloma. I told you microgranuloma, only 5 are required, 5 cells, right? So we tell our residents, granuloma means what? Cluster of epithelioid cells. How do they look like? Chappal. If you are not able to identify the chappal, you will get a chappal. So search for chappals, you will make a granulomas there. So we confidently gave it could be Crohn's, but I want to see the appendix. So we went back after 2 years, got the appendix from a lab and saw it. It looks like a regular appendix. Again, we've taken some more deep cuts. Anything you can make out? There was a granuloma here. So this is again granuloma around the vessel. So remember Crohn's, whenever you see in a microscopic biopsy or an excision biopsies, or you see, you look around the vessels and nerves, you'll find granulomas there. If that is there, probably you're dealing with Crohn's. You can see here, there's a vessel here, and there's a granuloma here. So this time we gave it as confidently as this is Crohn's. So patient got treated, his fistula, fissures, everything disappeared. That so-called megacolon disappeared. Patient is back to US. So when I called the patient's father, I told, sir, how is your son? I thought, I'll tell you, sir, big history is there. I thought I'm gone case. He'll put so he said, no, sir, he gave me the whole history. Everything got treated. Now patient is doing fine. So I'm sorry. for the animation which I put there. I should have done the animation a little more. So I felt like really Pushpa. I did like this. So two times I said, two times this is the cases which opened my mind. So I'll take it as everything as Qurans, unless proved otherwise, but I'll be hold my things. I'll not call everything as Qurans, but I'll look for Qurans. So what I would say, look at the age. Again, I want to just say that look at the history. Take care of the drugs is very important. Look what pattern you have got and make a equation with your gastroenterologist. What language they understand and treat accordingly. So you can go through these articles. This is the one book is very good, Endoscopic Biopsy Interpretation. This is a very good book, very simple language is written. You can follow this book. And all these articles are available online. So take out this and read it. I think you'll do good job. Thank you very much. Any questions? No questions means you are 100% confused. I would like always take deeper sections, because the technician, what they do is, because the tissue may be lost, again somebody will ask, so they just one, two sections they'll cut and give it to you. If it is not matching, take it deeper sections and put it there. I have taken deeper sections. In this also not there. You tell the gastro guy, rule out still deeper pathology. You do endosono and all those things. But from my side, I have taken deeper sections, because we are cutting at only 4 microns, 5 microns, right? So take deeper sections. This is what I will say. And drug history, very important.
Thank you, sir, for such an engaging session and valuable insights. So I think our postgraduates had understood the basic GI pathologies, and also the consultants. We used to regularly report like non-specific colitis, but I think we should reform our reports. And also, thank you very much for your insights, sir. Thank you, sir. Now I would like to request our HOD, sir, Dr. PJ Naidu, sir, to grace the stage. I would like to request our Dean, ma'am, Dr. D. Lakshmi Lalita, ma'am, to grace the stage. I would like to request our medical director, Dr. Hemant, sir, to grace the stage. I would like to request our Chief Operating Officer, Dr. Sridhar Reddy, sir, to grace the stage. We request all the dignitaries for the ceremonial. Now I would like to request our internal observer, Dr. K. Sai Lahari, ma'am, Professor of Psychiatry, to grace the stage. We request all the dignitaries for the ceremonial lamp lighting. I would like to invite Hemashri, Anjali, and Geetika for the prayer song. I would like to request our guest speaker, Dr. I. Satish Rao, sir, for lamp lighting ceremony.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठनामदेवादिवन्दित महागणपतिं महादेवसुतं महादेवसुतं गुरुगुहनुतं मारकोटि प्रकाशं शान्तं महादेवसुतं गुरुगुहनुतं मारकोटि प्रकाशं शान्तं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दित महागणपतिम्.
Thank you all respected dignitaries. Now I would like to request our HOD sir, Dr. PJ Naidu sir, to please address the gathering.
Good morning to everyone. I warmly welcome all the dignitaries seated on the dais, our dynamic Dean, Lakshmi Lalita Madam, and our Medical Director, Hemant Sir, and Chief Operating Officer, Sridhar Reddy Garu, and our Ma'am, Observer Ma'am, Sai Lahari Ma'am. Welcome, Madam. Welcome to our CME. And also extend my heartfelt welcome to our esteemed speakers, delegates, faculty members, and postgraduates to this CME. And a special, it gives me immense pleasure to welcome you all this continuous medical education program that offers insights in gastrointestinal pathology with a special emphasis on colorectal lesions, organized by Department of Pathology, James Medical College. This is a journal CME focusing on JA pathology, an academically rich and highly relevant program aimed at creating a strong environment for learning, discussion, and scientific exchange. We are honored to have eminent speakers with us today who are here to share their knowledge and experience, offering us an academic feast. And our institution has had a remarkable journey, beginning as a small institution college established by our founder, Dr. Sudhir sir, and growing into a major tertiary care hospital known for excellence in academics, patient care, and advancements in medical services under the vision of our chief mentor, Dr. Balaneni Bhaskar Rao garu, and our CEO, Advik garu. Today, James Medical College stands proudly as a center capable of performing complex and advanced procedures, including organ transplant surgeries, with a special recognition for liver transplantation. The Department of Pathology has played an integral role in supporting these achievements through accurate diagnosis and dedicated academic contribution. I want to take a moment for appreciate and congratulate our faculty for their hard work and commitment in making this event possible. Thank you. And once again, I welcome all the dignitaries and delegates with the CME great success. Thank you very much.
Thank you, sir, for your valuable words. And under your guidance, we make sure we'll be doing much more programs, scientific programs like this. And I would like to request our Dean, ma'am, to address the gathering.
A very good morning to everyone and a warm welcome to this CME. I just want to insist upon only one point, and why are these CMEs, especially on Sundays? Why to call many people? Why to call somebody from outside? Why are we all here wasting away our Sunday? Do you think there's a meaning for this? Do you think? I have not listened to the previous talk, the people who have spoken, but I've listened to a part of what Dr. Kishore Rao was speaking. I could really understand the passion he has for pathology and the way he was enjoying his subject when he was explaining, and the way he has made his slides and the way he was rolling on to the other slide. It was really marvelous. Sir, I don't think it's just for the students, it's for all of us to learn from you. It's wonderful. So we are not wasting this day. We are investing this day for a better purpose. So you really have to learn a lot. As he was saying, if you take only an upper section and give a upper slice and give a report which is nothing, and somebody asks you to go to a deeper section, what if somebody doesn't ask you to go to a deeper section? So the one asking you and the one doing, both of you should have good knowledge about what you're doing. And this knowledge will not be given in any textbook. It's out of experience. When people speak, you learn. So it was a very interesting talk, sir, I should say, though I joined in the middle. At the end of your talk, I could understand the chapel. That was very good, the granulomas you were mentioning about. So please, most of the times, as he was saying, please get up from your sleep and all. Don't be in a slumber. Utilize the day. Try to understand from all the people who are speaking over here, because definitely they're all experts, and their expertise is most of them, their expertise is far above your expertise, I should say, because you're just 1 or 2 year or 3 years old as postgraduates. So please learn and utilize this opportunity. It's not a formality that we are conducting a CME because university has asked us, but we are doing it with really a passion for conducting a CME. And I could really see that in the Department of Pathology when Dr. PJ Naidu and his team, they were really taking lots of pain all these days to really make it a success. And every part of it, they were so meticulously trying to do the best. And I should also congratulate Dr. PJ for his team, for the hard work they put forward, and for the dynamic department. So congratulations for all of you and all the very best. I wish you all a very, very happy academic learning. Thank you.
Thank you, ma'am, for your valuable words. And now I would like to request our medical director, Dr. Hemant sir, to address the gathering.
Thank you. Good morning to all respected dignitaries of on the dais, off the dais, and my dear delegates. So, welcome. First of all, welcome to GEMS. As a part of multiple CMEs, or rather interdisciplinary CMEs, which have been started recently by us. The basic idea being a coordination between the stakeholders related to a particular topic to improve the coordination and to improve the outcome in the patient care. So this is one such effort which has been going on. Apart from this, gastrointestinal pathology is a very complex subject which we commonly classify as irritable bowel syndrome or an irritable bowel disease. But after going through the guest lecture of Dr. I. Satish Rao Garu, so we can understand the intricacies in the subject, or rather the number of pathologies which can be associated with this simple term IBD or IBS. So apart from this, I also would like to stress on the point that the importance of history and the detailed examination, which could lead to a differential diagnosis and a difference in the diagnosis, thereby resulting in the outcome of the patient by the presentation which Dr. Satish Rao Garu has very rightly shown. So the basic idea is in by attending such lectures, each one of us will be enlightened during the course of the day, and this could help us in improving the diagnostic skills and at the same time improving the patient outcomes. I'm sure all of you will be listening to more important lectures during the course of the day, and at the end of the day, go out enlightened with this CME. So I once again welcome you all and wish you a happy learning. Thank you.
Thank you, sir, for your valuable words. Now I would like to request our Chief Operating Officer, Dr. Sridhar Reddy, sir, to address the gathering.
Respected dignitaries, teachers, students, the university is taking a lot of interest in arranging such CMEs. In turn, the colleges are making their own efforts to arrange this type of CMEs. I'm just not talking about the CME of a pathology here, but in the whole. And most of the time, any subject is not isolated. All the subjects have interrelated. The meaning in this is today, the CME of the pathology which is going on J pathology, it's a cross-departmental. So I know that most of the people got registered. I was just talking with PJ Naidu sir. There are more than 200 people registered, but 50% present here, other 25% present on the paper, and other 25% has not turned up. And I was seeing when I'm coming in the morning that the 25%, some people are coming in the night dress with bathroom chapel, signing and taking their papers and going off. It is just for the certificate purpose. Make sure that we'll give you the certificate. If it's the knowledge purpose, then it's completely a different issue. Your certificates will not help you in future for anything, because neither the patient is going to ask your certificate, madam, how many certificates, how many gold medals you had, please show me, before sending any patient or anything. Or your consultant will never ask you, sir, this pathologist had how many certificates, sir, to send me the bit and pieces. No, they're going to test your skill and knowledge and how well you're going to interact. And a very good example now placed by Dr. Satish Garu about this thing, how important it is to interact with the consultant, with the patient history and everything, and knowing completely in-depth nuance about how to process the tissues or what type of sections to be taken and all this thing. And always pathology was a very interesting subject. Myself, being a forensic medicine, worked as forensic pathologist in UK. And whenever I do the pathological autopsies, most of the time I feel proud for that thing. The reason is most of the time you people see all formalin specimens. And I used to see a specimen which is alive with all the colors and everything. So I used to really, the type of pathological changes it used to, I used to feel so thrilled. And I used to send the pieces for histopathology. But of course, the end of the day, the pathologist used to do for him. But the specimens used to be read myself. So now when I'm listening to this much of knowledge, I was never having it because I was concentrating more in forensic medicine. I thought if people like this would have given me CME programs at that time, I would have done a better job. So I request all the students to utilize this opportunity of learning, not getting certificates. So just getting certificates makes no sense. Thank you.
Thank you for your suggestions, sir. Now I would like to request our observer, Dr. K. Sai Lahiri ma'am, to address the gathering.
So good morning. So from the major two sessions which have already got completed by Dr. Vamsi sir and Satish sir, one major thing, they took all the pain to interact from the clinical approach first. So the major importance of today's CME topic, one thing, it is the commonest thing which most of the time as clinicians you face and as pathologists they reach to the laboratory. From the undergraduate session, so you people as a part of volunteers, always give the emphasis of clinical history taking first. You PGs try to interact with other departmental multidisciplinary approach, which is very, very essential. And see the pattern of the teaching here. First, always going with the history, then taking the lab thing, and once again going back if they have any doubt. That reciprocation, that consultation liaison is very, very essential. Now, being a part of Observer, let me give that compliment and comment that you people are interactive. Try to utilize these sessions and make them more interactive. Thank you.
Thank you for your suggestions, ma'am. Let's make this session more interactive as your words, ma'am. Now we shall have a short tea break, and just I request all the delegates to reassemble shortly after a break. Thank you, ma'am.
determines the completeness of resection. Adequate lymph node evaluation ensures correct pathological staging. Direct impact and multidisciplinary decision making essential for audit, accreditation, and institutional quality assurance. Coming to the margins assessment in GI cancers. Margins represents the interface between tumor and surgical resection planes. Positive margin indicates residual disease risk. Different GI organs have unique anatomic and surgical margin considerations. Requires meticulous grossing and appropriate histological sampling. Types of resection margins in GI cancers: longitudinal margins, circumferential margins, and specialized margins. Longitudinal margins are the proximal and distal margins in luminal cancers. They are assessed for mucosal and submucosal tumor spread. Circumferential margins represents the non-peritonealized soft tissue margins. These are critical in rectal, esophageal, and pancreatic cancers. Some specialized margins in like HPB cancers, hepatopancreatic biliary cancers like pancreatic neck, bile duct, and vascular margins. Back. Yeah, about the standard definitions in the margin assessment, you all know about R0 resection. There is no tumor at any resection margin, microscopically negative. And R1 is about microscopic positive margins, but macroscopically there is no tumor. R2 is macroscopically residual tumor. The clear definition and documentation are mandatory in the pathological reports. There's a clinical impact of the positive margins. There's a higher risk of local recurrence, adverse effect on overall survival and disease-free survival, influences need for adjuvant therapy like chemotherapy or radiotherapy. It's an important prognostic factor in TNM staging. Organ-specific margin considerations. In esophageal cancers, the proximal, distal, and circumferential margins are critical. Circumferential margins positivity strongly correlates with the local recurrence. In stomach malignancies, the proximal and distal margins and submucosal spread is very important. Diffuse type cancers require a wider assessment. In colorectal cancers, CRM is the key in rectal cancers. Less than 1 mm clearance associated with the poor outcomes. In pancreatic cancers, multiple margins are to be assessed. Standardized protocols are essential. High R1 rates reflect complexity rather than the poor surgery alone. Coming to the lymph node yield in GI malignancies. Lymph node status is the cornerstone of the TNM staging. Adequate lymph node yield reduces the risk of understaging. Node negative status is meaningful only if sufficient nodes are examined. It reflects both surgical clearance and pathological diligence. The recommended minimum lymph node yield in esophageal cancers, it should be minimum 15 lymph nodes. In gastric cancers, it should be the minimum lymph nodes yield should be 16. In colorectal cancers, the minimum lymph node yield should be more than 12. In pancreatic cancers, it should be more than 12 to 15 lymph nodes should be examined before confirming the node negative disease. So prognostic significance of the lymph node yield in GI cancers, higher node yield associated with the improved survival even in node negative disease. The higher probability of detecting micrometastasis supports adequacy of the oncological resection. Factors influencing the lymph node yield are surgical factors, pathological factors, and patient and tumor factors. Coming to the surgical factors, the extent of lymphadenectomy, surgical technique and experience. Pathological factors, careful fat dissection and use of clearing solutions or fat dissolution techniques. Patient and tumor factors, age, obesity, tumor location and biology, and the effect of the neoadjuvant therapy. The grossing techniques to improve the lymph nodal yield. Systematic and methodical dissection of the mesenteric fat, thin slicing and palpation of the adipose tissue, submission of all the identified nodes, use of fat clearing methods in low yield specimens. The impact of neoadjuvant therapy on the lymph nodal yield in GI cancers, there will be reduced lymph node size and number, fibrosis and treatment related changes obscure nodes. Lower lymph node yield does not always imply inadequate surgery. Pathology report should mention about the post-treatment status. Standardized pathology reporting, use of CAP or RCPath, ICCR datasets, clear documentation of the margin status, exact lymph node count and number of positive nodes, a comment on the adequacy and limitations when applicable. Margins assessment and lymph node yield as the quality indicators of the GI oncology is used for institutional audits and benchmarking. They reflect multidisciplinary performance, important for the accreditation and cancer registries. Encourage continuous quality improvement. The common pitfalls in practice are inadequate orientation and inking of the specimens, failure to recognize true circumferential margins, incomplete lymph node retrieval, ambiguous or inconsistent reporting terminology. A take-home recommendation, adopt standardized grossing and reporting protocols, ensure meticulous margin identification and inking, aim for recommended lymph node yield in all resections, document reasons when benchmarks are not met. Conclusions, margin assessment and lymph node yield are critical determinants of the patient outcome. Pathologists play a pivotal role in accurate staging and treatment planning. Standardization and diligence improve oncological care and quality. Continuous audit and education are essential. Thank you.
Thank you, sir, for your clean and clear explanation regarding what the consultants want from a pathology report. Now I respect our dignitaries, Dr. PJ Naidu, sir. Sir, Swami Naidu, sir, please stay back for a moment on the dais, sir. I would like to request our medical director, Dr. Hemant, sir, to please come on to the dais to felicitate Swami Naidu, sir. I would like to request our Chief Operating Officer, Dr. Sridhar Reddy, sir, to please come on to the dais too. I would also like to request our Dr. PJ Naidu, sir, to felicitate Dr. Swami Naidu, sir. Thank you, sir.
We now move to the grossing and reporting of the colorectal carcinoma.
The speaker is our revered guest, Dr. I. Satish Rao, sir, MD Pathology, AIMS, Senior Consultant Pathologist, Lead Histopathology and Cytopathology Division, KIMS, Secunderabad.
Okay, so I thought I'll also give some Osmania biscuit and chai to you because this is going to be a little exhaustive talk. I hope I can do justice. I may cross 1 hour, but I think this will tell you a gist of everything what goes in pathology. I've tried to put even a molecular part to explain to the residents. Because once you understand this, I think everything becomes very easy. Okay. So as usual, I see the front benches now sitting behind again. That the chai was not effective, I guess. So they are probably trying to catch some sleep. So this is grossing and reporting of colorectal carcinomas. As Dr. Naidu said, nodes and margins. If you are wrong in that, the surgeon will never believe you. So the diagnosis Nibada is a pathologist headache. Mostly the surgeons won't be so concerned about that subtype what you're dealing with. Margins వచ్చిందా లేదా, nodes ఎన్ని వచ్చాయి. Because the moment you land up with for a second opinion in another city or another doctor, అరే సర్జరీ బాగా అవ్వలేదండి, మార్జిన్స్ చాలా క్లోజ్గా ఉంది, నోట్స్ అంటే ఇంకా డాక్టర్ నాయుడు విల్ షూట్ యూ డౌన్. Right, sir? I'm just joking. Please take it in a lighter note. So, those who want to go for grossing, what are the points to be asked? This is one website, ICCR, International Collaboration of Cancer Reporting. Everything is available online. So, if you are following CAP protocol, it's fine. If you are following ICCR also, it's fine. But do follow some protocol. Don't write that essay like a Shakespeare laga 4-10 line rasi. No, not accepted. In this date, you have to give a synoptic reporting, and that means you have gone through a checklist. Have you answered all the questions? Life will be very easy because grossing also becomes very comfortable and the reporting also becomes very comfortable. You will not forget anything. Okay, so thanks to the organizers, I thought what is the latest thing which has come up. So if you can go this is just October 25. This article has come, it is freely available. All the questions about the polyp has been answered. Pathology of malignant colorectal polyp. Why I'm asking is the gastroenterologists now have become more active. They say, why should I give it to a surgeon? I'll do it myself. So the polyp, so now the gastroenterologist also is behind you now. Is the polyp removed properly? The margin is free or not? Does it have a carcinoma or not? So the criteria have changed. So now you are double whammy. Now the surgeon is also behind you, the gastroenterologist is also behind you. So both are behind you now. So I think this is one which is, just go through it. This is October 2025. Very latest article. It's given in a question answer basis. It is given. A very beautiful article. So I'm not going to bore you with how to recognize a polyp and all those things, but you should know the terminologies, conventional adenomas, adenoma with epithelial displacement and all those. So why I have changed it here is, there are two parts of the grossing here involved. One is the polyp grossing and another is a colorectal specimen grossing itself. Both are slightly different. So this is all the terminology. Serrated polyps, a big terminology is there. I'm not going to grow. So what you understand is, if you have a pedunculated polyp, you should measure the size of the stalk and also take sections through the stalk, because that is the margin actually you are dealing with. And suppose you have a sessile adenoma, then also you need to understand the margins. So now is very frequent now, every hospital now, the gastroenterologists are very well trained. They either remove the polypectomy as a piecemeal, or they do an EMR, endoscopic mucosal resection, or a endoscopic submucosal dissection. So EMR, ESD, TEMS, TAMIS, all these words will be, if you are in a high volume center, these are very common. So what they do is, they identify the polyp, they do a resection of the polyp, they leave the base around, then they sent with the mucosal membrane like this. Are you able to see this? Yeah. So now if you see, so you have to take a sections. If it is 1 centimeter, through the stalk you cut. Have you seen broccoli? All of you know broccoli now, right? So cut it into half and put it there. So like that, or if you say bigger piece, you have to take at least 3 sections from the stalk and rest all embed. So you have to embed everything. And when you have a mucosal tissue, you have to ink them and also take the margins. So see here, this is a polyp here, you're able to see. It is to be pinned like this. It has to be pinned, the mucosal membrane is on a foam. It is to be pinned like this and they send. You ink and take the margins from the polyps also. This is very, very particular, extremely important. 1 millimeter, 2 millimeter has to be measured. Those who have a digital microscope, like I came to know GEMS has got silica, right? It's got an iPad. You actually can measure in that also you can measure the distance of the margin from the tumor if you have. So see here, this is a carcinoid tumor. Now these kind of tumors, they won't do a big resection. They just do endoscopic mucosal resections. So see this. You're able to see this? This is the mucosa, and that is the tumor there. So you're supposed to comment on this margin and also the base margin. So what you are supposed to see is any polyp which is more than a centimeter, it is not a good polyp. Means it may harbor malignancy. You cannot say that it's benign. A larger polyp, the higher chance of malignancy. So those who want to take photograph of this, if I'm an examiner, I'll ask you these questions. What do you define as low-grade dysplasia in a polyp? What do you define high-grade dysplasia? So basically, low-grade dysplasia is parallelly arranged crypts, back-to-back configuration, without back-to-back configuration, no cribriform, no complex. And the nuclei are pseudo-stratified, but they occupy the lower half of the cell cytoplasm. Once the nuclei reach the lumen, it is an indicator that, okay, this is a high grade, and you have a complex architecture, you have prominent nucleoli, open chromatin. So now can I ask you one question? What is the difference between the staging of a colorectum and stomach? Can anybody, exam going, 3rd year PG? Are you aware of the staging of the colorectum adenocarcinomas? So this is why it is important here is, whatever polyp is removed, that is known as local excision of specimen. Whatever is the whole colon or something is come out, that is radical excision basically. So local excision means polypectomy and all those. So here you should understand the staging. So here there are 2 differences between a gastric staging and a colorectal staging. And can anybody guess what it is? Okay, I'll tell you the gastric staging. Then you can tell me the difference between. Please be interactive, or else I'll sleep off. So the gastric staging is, if you have a carcinoma, neoplastic glands in the lamina propria itself, it becomes T1, right? Then, understood? Intramucosal, if the mucosa, it breaks the mucosa in the lamina propria, it becomes T1, right? Then if it crosses the muscularis mucosa, some other staging. If it is into the submucosa, some other staging. It crosses the muscularis propria, some other staging. So what is the difference of the colorectum as compared to gastric? First, you have to understand that one. Anybody? Anybody? So first you have to understand that. Okay, count of 5. Anybody? No. So what happens is, the carcinoma colon, till the adenocarcinoma crosses the muscularis mucosa, it has to come through into the submucosa. It becomes in situ only. That you understand. In in gastric, just in the lamina propria, it is invasion. But in a colorectum, the tumor has to cross the muscularis mucosa to come into submucosa. Till then, it is in situ. That is one difference, right? And the other difference is nodal status. Are you aware of nodal status? There is one N1C category in colorectum. That is, if you suppose, as sir told, nodes, how many nodes to be removed? Sir, recently now it has now changed to made to 15. Previously it was 12 only. So recently they have made 15. Last few months back, they have made into 15 because the amount of surgery, mesocolic resection has improved. That's why from 12 they have changed the number of optimal lymph nodes to be resected is 15. So you have a scenario where you have 15 nodes, all are negative, but something you find and you say it is N1C category. What is that? Anybody? Mesocolic deposits or soft tissue deposits. That means a node was there, it has been now replaced by a tumor. It should not be continuous with the main tumor. So that you call it as N1C. It means 15, 16 nodes have come out, but all are negative, but you found a tumor deposit in anywhere in the mesocolon or wherever you have found in the soft tissues. It is, you call it as perirectal soft tissue or pericolic soft tissue. You call it as N1C. So these are the two differences of the staging you should remember. Now you will understand this. See, now this is the polyp. So you see here, you have to say the tumor, what kind of tumor it is. You have to say well differentiated, poor, and worst area. What is the worst area? Sometimes that category is the more than 50, less than 50. No. In colorectal, they usually say worst type, which is a poorly differentiated is there. That is the word worst differentiated. You give it as poorly differentiated. And there is also one entity known as tumor budding. Are you aware of this tumor budding? How do you remember tumor budding? Very simple. Buds, BUDS, 4. So if you have cells less than 4, cluster of less than 4 cells, it is budding, tumor buds. Okay, so you have to look at the tumor budding. If the budding is more, it is a predictor for lymph node metastasis, adverse prognostic factor, not related to lymph node metastasis also. So every cancer, especially polyp, with a malignant polyp, and even in colorectal resection specimens also, you make it a habit that you have to search for tumor budding and say BD2, BD3 or BD1. You can go and see the criteria, how to cap protocol, it is given everything, you can go. Then PDC is what? More than 4. If you have more than 4 cells, poorly differentiated clusters, you say present or absent, that's all. So now you can see here, this is the carcinoma, cribriform. This is the muscularis mucosa is being infiltrated here. And you have to see the tumor budding. So buds are, as I told you, they are counted at 20x. Less than or equal to 4 is 1. 5 to 9 is BD2. And more than 10 or more are BD3. So please understand this. This is mandatory. It is now mandatory. Tumor budding you have to give. And this is a stronger indicator of lymph node metastasis as compared to poor differentiation or lymphovascular invasion. What they say is the cells become mesenchymal transition. They become mesenchymal type of morphology or the physiology. So they become more invasive. So it should not be assessed in active inflammation, glandular rupture, or mucinous differentiation. So now another thing is, as I told you, PT1. So the staging has to be given in all polyps with cancer. Please try to understand. It is in situ or PT1 or whatever it is you have to give. Plus, you are also supposed to comment upon the levels of invasion. There is one Haggett level and one Kikuchi levels and all those things. And you have to also comment upon the margins. So this is one thing which all of us think, what is the importance of margin? No, everything has got importance. If you are working in a high volume center, every line is read, every millimeter is given importance. Now, there's also one more problem in the polyps is, especially in the sigmoid colon, because the stalk is there, it will be rotating because of stool movements on peristalsis. So some of the glands will break down and go into the submucosa. That is known as epithelial displacement. That should not be called as adenocarcinoma. So there are many criteria. If you are able to draw around the cluster of glands, this is probably a displacement, not a cancer. And this is an invasive cancer. You see here, irregular glands, the dysplasia is very high. So there are many differences between these two. This one more clue is you see hemocydin and macrophages in the polyp, and there's an epithelial, this is more like epithelial displacement. I hope you understand the physics behind it. A stalked polyp may undergo like torsion like this, and the submusculus mucosa will break, and the gland will just go inside. That is to be interpreted as epithelial displacement. So now this is the margin. Now let us be a little more interactive. Probably you would have got bored by this talk. Let us see. So what happens is when the polyp is removed, you get specimen like this, and you have to understand the physics of this structure. Okay. You see this is the margin actually. So if you don't have ink, no problem. Look at the cautery artifact, that is the margin basically. Okay, so this is the normal mucosa and there's a dysplastic mucosa. So what happens is, because the diathermy plane is there, it goes inside, and the vessels still remain strong, and you have coagulation zone, and the soft stroma may evaporate in this. So what happens is, now tell me which is the margin here. Is this the margin? How many you say this is the margin? Please raise your hand. You understood this is the higher power of this, what I'm showing. How many of you think this is a margin? Good attempt. That is not the margin. So what happens is, because the tissue is variable, right? There's the vessel, there's soft tissue and all those things. Actually, the margin becomes like this. So best way is put an ink, so that once the section comes, you can measure the carcinoma from the distance. I hope you got this point clear. So where is the margin now? Which is the true margin here? See, that is the carcinoma focus there. This one or this one? Exactly. So that is not the margin. That is the margin. So diathermy. So best way is you use two markers, diathermy margin and also the ink, so that before cutting you have to apply the ink, because if you don't apply the ink before cutting, the ink will seep in and you will interpret that as a wrong margin. So you have to be very careful. So here, as I said, 1 millimeter is taken as R0. Less than 1 millimeter, how you measure? So sometimes you use digitally, you have to measure, right? So that's what I say. If tumor is within the less than 1 millimeter of the peripheral mucosal, submucosal or muscularis propria margin, is considered as R1. Less than 1 millimeter means you have to say, you have to count that in less than millimeter. Suppose you see an artifact like this, you are not able to make out, you give it as involvement. Better to give it as involvement. So this is one more thing is, many of the gastroenterologists, they would like to have this Haggett levels. It is very cumbersome to remember. What you understand is, if you have a pedunculated polyp, you see which level it is the carcinoma is invading. So level 1, level 2, level 3 and all those. What you understand is the neck is important here. So if the tumor invasive carcinoma measurement is more than 3 millimeter, it has more than 10% risk of nodal metastasis. If it is tumor in the head, it is very less chance of vascular involvement. The more closer to the vessels, it's more chance of. So you have to understand, if it is a pedunculated body, you have to give Haggett levels, or now they say leave it. Just measure this distance and give it 2 millimeter, 3 millimeter. Suppose you have a sessile polyp. Wait. You have a sessile polyp. You have to give depth also and also the width also of the carcinoma, not the whole polyp. That will decide. So for example, if you have, see here, if you have low risk is depth less than 1 millimeter, width less than 2 millimeter, you have less chance of lymph node metastasis. As the depth is more than 2 millimeter, just millimeter difference, more than 2 millimeter and width more than 4 millimeter, almost 25% chance of lymph node metastasis. So this is done. So now I'll skip this. Let me see. All of you, please exercise your brain now. This is the question answer session. The more slow you are, I'll become more slow. Name the subtypes of carcinomas of colorectum. Some subtypes at least. Well differentiated, mucinous, yes. So there are many actually, but you should understand adenocarcinoma NST, mucinous, signet ring, medullary, serrated, micropapillary, adenoma-like adenocarcinoma, right? So you have to understand now you as a pathology resident, whenever you read a chapter, what are the aggressive ones? You first put it in your mind, these are the aggressive ones. Any cancer report is there, you first see aggressive or not, you say aggressive variants not there. That's it. That gives the quality of the report improves. You just have said these aggressive variants are not there. You have to look for these aggressive variants. So what is it? I already told you, I leaked this question. Difference between staging of colorectal from rest of GI tract. In situ and N1C. This you have to remember. If there is a tumor perforation, it upgrades to T4. Fantastic. So is there any difference between in intraoperative or iatrogenic? Your surgeon should be very true to you, right? Surgeon should say, yes, when I was delivering the specimen outside, inside the abdomen it got ruptured, perforation, that becomes T4. He says, I took it out on the table, have put and taking photographs or something, that time it got ruptured, it remains the same stage, T3 or whatever it is. So here you have to, the surgeon should be open to you. Okay, so you had here this some change has come. So, and nodes, yeah, madam, 15, yeah, correct. So as sir told, Dr. Naidu told that after post chemotherapy and RT status, you may just get 5-6. So if the surgeon is getting angry, you tell him, Anna, radiation ichcharu kada, nodes takkuve vastayi. Kavalante na nodes istan tisi, deenso takkuva vastayi. So basically you should have the history of post chemotherapy or radiotherapy status undala. So you should always, before interpreting, you should always ask, is it pre-treated? Because now these days they downstage and do a surgery. Next, what is the point of reference of tumor in AP or AR? Where do you say it is below pectoral reflection or above pectoral reflection or at which one? No, it is the anterior peritoneal reflection. So if it is above that. It is below, it's below. Right? And PRM and DRM assessment is not required. Means posterior proximal and distal resected margin are not required when it is more than 3 centimeter. However, if it is aggressive, signet ring or high grade or undifferentiated carcinoma, you have to supposed to take the margins also. Because as I said, a tumor can come from the mucosa or submucosa side also. So here one more clue. Actually, Dr. Naidu, when you are doing, you'll also get donuts, right? So how do you write the description for donuts? No, how do this donut margins? When you get donut specimens, how do you write it? Measuring 3 into 3 into 3 into something you write? Right? That is wrong. Because you should understand that you just say that what is the thickness of the donut, that's all, enough. Because that adds to the margin actually. Then the surgeon will be very happy. Even you say the main tumor margin is only 1 centimeter. However, the distal donut, suppose distal margin is just 3 millimeter or 4 millimeter. However, the donut is 1 centimeter. So actual becomes 1 plus 4 millimeters. So 1.4 centimeter. Surgeon will be very happy. My margins are free. Nobody can question. So you write the donut margin just beside the margin, distance of the margin you write. So you know that you can add up and say, okay. I hope all of you got this margin assessment, right? Now, what is the meaning of this C, P, R, A, Y and all this? What is the meaning of this? Can anybody say? C is clinical. Okay. P is pathological. R is no, recurrent. A, Autopsy. Autopsy staging. Why? Post-therapy. Radiation or chemotherapy. What is post-therapy? What is this brackets M? Multiple. MX. So in your report you write PT2 NX MX. You should not write. Khatam. Don't write MX. If you have tumor and you have got nodes, PT3, N0, N1, N2, close. Don't write MX. MX is outdated. Khatam. Okay? And if you want, you can give R status, but the surgeons are wise enough. They will know R1, R0, R1, R2, they'll know. Capital R is, so small r is recurrent. Capital R is margin. So you need not write that. Don't put it in the, it will be understood. You say microscopic margin is involved, right? Okay, now, Naidu Garu, please interact with me. Suppose I write, be very frank, suppose I write the margin, the distal margin is involved by tumor. What is your reaction? You will accept it or you will ilaga కోపంతో మింగేస్తారా? So what we do is we actually say the right thing, Ashwathama Kunjara types. So what we say is one of the sections taken from the distal margin shows microscopic tumor. That means the surgeon is saved. Okay, the surgeon says, you say blunt ga rasesta margin involved ante gone case adi. The patient says, how did you give the involved? You say the surgeon will become your friend. Okay. Okay, now, so now what I want is, the minimum expectation I expect from the surgeon is preoperative therapy given. Is there any iatrogenic defect, any inflammatory bowel disease, or any polyposis Lynch syndrome is there or not? So, sir, how much time I have got? Right, sir. So I'll jump to some of what are the minimum data you have to give is extent of local invasion, PT, then lymph nodes, how many nodes, CRM involvement, distance of margin from tumor deposit. This is one important point which I would like to tell you. Quality of mesorectum and extramural vascular invasion and all those. So if you see, look at the anatomy of the colon, it is like Arku Valley. Okay? Means the tumor is going through various coverages of peritoneum. So one tunnel, then another tunnel, another tunnel. So depending on where it is there, the mesocolon will be thin or broad, For example, transverse colon, it will be thin, margin will be thin. Descending colon, it will be wide. In the upper rectum and all this. So you should understand which part it has been dissected. So it's not like everywhere it is thin or this thing, it will be changing. So this is what I was telling you. See, this is an APR and this is the anterior peritoneal reflection. If it is at this level, you say straddles. If it is below that, below the peritoneal reflection, it is above, you say it's above the peritoneal reflection. This is AR. So here, I would like to take to one more point here. I have already told about the donut cut margins. Yeah. So mesocolic margin is very important. Here you have to say that that 1 millimeter cutoff point is everywhere. Let it be a polyp margin, let it be a mesocolic margin, let it be a CRM margin, that 1 millimeter will not leave us. So this 1 millimeter, you have to be very careful. If you give positive margins, mesocolic margins, 20%, the 5-year survival is 20% and 85% risk of recurrence. If it's negative margins, 5-year survival is 75% and 10% risk of local recurrence. So this is mesocolic margin which needs to be really sampled. So I will show you, the therapy effect is very important. If you have a history of therapy, then you have to interpret in a different way. So what happens is, suppose you have a mucin secreting adenocarcinoma, right? If it is a non-treated, just mucin at the perforation, at the margin, you take it as involved. If it is treated, Then disregarded that mucus. You see from the viable tumor, you measure the distance. That's what I was put it here. For mucinous adenocarcinomas not treated, acellular mucin is at resected margin should be taken as margin involvement. I hope you understood the difference. The tumors may be somewhere, but the mucus is reaching the margin, you give it as involved. Post-therapy status, disregard. This is what one point to take care. So now here, what do you say about is the margin free or not? Is the margin free or not? Anybody? Actually, look at it carefully. The margin is free, right? Sorry for the arrows, but here the node is there, is present at the margin. So you have to specifically say that the primary tumor distance is so much, the margin is free. However, see, this is the vein here. There is a vein there, right? This is what is known as extramural veins, outside the muscle veins. So vein involvement, or if there's a vein is involved, or a nerve is involved, or a lymph node is involved, or a tumor is involved, you have to measure that distance also. This is what I meant here. See, non-peritoneal surface, you have to say the distance between the nodal deposit, vessel, or whichever is, or primary tumor, whichever is closest. So you are actually telling that primary tumor is free, but the deposit and everything else is involved. So I'll skip this. Only one point here is when your serosal surface, the appendices epiploicae are covering the whole surface. So you may actually miss that serosal breach. See, for example, see here. This is a simple, small place where the tumor is actually infiltrating. You would miss grossly. So you actually, wherever there's irregular serosal surface, you actually open and see the appendix epiploicae, put the ink and take a section. So that becomes T4 straight away. Right. So this is in UK and all those places, you are supposed to actually also rate the type of resection. Is it a complete mesorectal resection, nearly complete, or incomplete resections? So based on that, the surgeon may be told, please stop, sir, don't operate. So the audit happens in UK. If anybody from UK can please correct me. This is what it happens is the margin assessment is done by the pathologist. If too many margins are coming positive, the surgeon may be told, don't operate. It's something like that. So you have to be these are very, very particular. I have taken it from RC Path. So that's why I am just skipping through, because it's very toxic for everyone. I'm just skipping through. Just go through the RC Path. You will get everything on this. They have explained very well. Right. So now, how many of you cut the colon longitudinally? How many of you cut the colon longitudinally? None of you, right? Right. So how do you open the colon? Anterior tinea coli, correct? And you have to cut slice. I hope you understood the reason why you should cut it, right? So I'll just skip this. All of you know this. Now I'll skip to, this is the perforation, which sir, I think Naidu sir will take care about the talk later on. That's why I'm skipping this. Thank you, sir, for relieving me. So now once you know post-therapy status, you should give a RAN scoring. RAN scoring, right? Every tumor which has post-therapy status, you are supposed to give tumor regression score. So just go down, tumor regression score. In every CAP protocol, it's given. What score you have to give. So please follow that. Please give a regression score. Now they say regression score for tumor and also regression score for nodes separately. Suppose you have a node with only mucin, post-therapy status, involved or not involved? Not involved. So post-therapy status, not involved. If you want to be doubly sure, do an IHC with CK, no cells. Give it as free. But you have to give a regression score, RAN score. You have to give for separately, you have to give. For node also, madam. They have changed. Recently, they have changed. For node also, you have to give. So I am skipping this. I just to summarize this, right? Now comes the role of the pathologist now. So now we are like Jatakam. Okay. We are supposed to tell the Jatakam of the tumor, right? So how the patient is going to behave? How is the tumor going to behave? What drugs will work on this? So we are supposed to be proactive. We have to interact with the surgeon and medical oncologist and everybody. You should be predictive, you should be preventive, and you should be personalized. So I hope I'll take 15 more minutes. I really need your concentration because it's very difficult. This is for the exam purpose. Those who are giving exam, if I ask you a question, what are the different pathways by which a colorectal carcinoma happens? Huh? Yeah. So put it in a little stylish way. You're right. There are 3 pathways. Easy to understand. Chromosomal instability pathway. There are 3 instabilities here. One is a chromosomal instability pathway, KRAS and P53. Another is epigenetic instability, where MLH1, P16, BRAF mutation. And there is microsatellite instability. There are 3 instabilities. Understand? Chromosome, epigenetic, and microsatellite. This is the exam. If I ask you this question exam, you should give me 3 answers. Chromosome, epigenetic, and microsatellite. So now what happens is, the carcinomas can go any differentiation. So by looking at the morphology, can you suspect that this could be MMR deficient? Are there any criteria? Yes. If it is proximal colon, poor differentiation, mucinous, or prominent tumor infiltrating lymphocytes. If you have these 4, you may suspect, but the pathway are different. So you will be, so medical oncologist, you will be surprised why he is asking so many questions, so many tests. He'll ask for tumor mutation burden. He will ask for BRAF. He'll ask for KRAS. Hinduki, what is this? What is unnecessary billing? No, there's a reason for it. You'll understand from this. So I'll skip this. So what you understand is, the most common pathway is chromosomal instability pathway. You have a epigenetic pathway, and you have a microsatellite pathway. That is what is known as Lynch syndrome. Right? So if you remember one pathway at least, for chromosomal instability pathway, RAS mutation is one important path. And second is BRAF mutation for this epigenetic pathway. And MSI is for MSA pathway. So these are the 3 things they require mandatory. This is done mandatory now. So now you understand. Now this is one. You understand this MAP kinase pathway. This will not even restricted to colon. It is every organ. This is what is. So where is the MAP kinase here? Although it is known as MAP kinase pathway, but where is the MAP kinase? That is MAP kinase actually. What is ERK is known as MAP kinase. So if you just apply your common sense, suppose I give anti-EGFR, right? So EGFR acts on KRAS, BRAF. So MEK is MAPK kinase and MAP kinase, and that will act on the nucleus. So this is the normal cell, how it functions. So if suppose I give anti-EGFR, the whole process blocks, right? If I give tyrosine kinase inhibitors, then also the whole process blocks. This is how it works in lung and all other organs. You have this Deftinib and all those things, right? So when you give this anti-EGFR drugs, the whole process blocks. Like lung, this is very common. Suppose you have a KRAS mutation, right? The anti-EGFR drugs won't function because below the KRAF, the BRAF, MEK, and MAP kinase, they don't listen because this anti-EGFR, because the KRAS is mutated, the tumor will progress. Similarly, if you have BRAF mutations, you give whatever drugs anti-EGFR, because of BRAF mutation, this also won't respond. Right? So this is how you understand wherever this BRAF thing comes or MAP kinase comes or EGFR comes, this is simple. EGFR, KRAS, BRAF, MAPK kinase, MAP kinase. That's all. If this 5 you understand, you are done with it. Right. So now, why should you do a Lynch syndrome testing? MMR testing. It's a prognostic and predictive marker. If you have MSI H or MSI high, earlier stage and lower recurrence. And if you have MSIH, it will not respond to 5-fluorouracil therapy. And it is also a marker for immune checkpoint. This is what is the latest thing. Nothing works, immune checkpoint works. So I'll just skip. So now this is the GI, the whole GI cancers. If you see here, you have this whole testing going on. The oncologist will ask for all these tests. So you nearly need to be geared upon by doing MMR or MSI, HER2 new expression. So what is this MMR and what is this MSI? Can anybody tell me? MMR is mismatch repair protein and MSI is microsatellite instability. So what happens is, whatever there are these small DNA things, nucleotides will be there, they will get mutated, and that is corrected by this mismatch repair proteins, right? So you understand, if it is mutated, there will be new protein, right? If it is a new protein, the lymphocytes will say this is foreign. So you'll understand now why when you see a lot of tumor infiltrating lymphocytes, it may be more chances of microsatellite instability indirectly. Got my point? Similarly, tumor mutation burden. You see this tumor mutation burden? Tumor mutation burden. So this we cannot do. We have to do under the molecular technique. But indirectly, if you have microsatellite instability or you have MMR loss, you can say, okay, the tumor mutation burden will be maybe high and it may respond to this PD-L1 therapy, anti-PD-L1 therapy. So if you go to the residents, if you go through this, it is too complicated. What are the molecular subtypes, CIN type, GS type, EBV and all those things? Frankly speaking, I also don't understand. Don't waste your time on this. If you're going towards molecular, leave it. Then you understand this. So what you should understand is, what is MMR? How to interpret. So there are how many, can you name MMR ISCs? Very simple way to remember. MLH1 controls PMS2. MSH2 controls MSH6. That's all. Very simple. Okay. See, for example, see, this is the one. When to suspect, right-sided location, age less than 50 years, tumor infiltrating lymphocytes, lack of dirty necrosis, Crohn's-like reaction, mucinous differentiation, medullary features, or well differentiated. All this can tell you that probably you are dealing with a MMR. Which other tumor is associated with MMR, microsatellite instability, or MMR? Correct. Why it is important? Which one comes first, colorectal or endometrial? Endometrial actually comes 1 decade earlier. So in a way, now if any lady who develops an endometrial carcinoma at a younger age, do an MMR and say, boss, get tested for Lynch syndrome. Maybe later on you'll get a colorectal carcinoma also. That's how it is now. Predictive, you're able to predict, right? So now, if you see there's a lot of articles, I think you will get bored of this. What I'm telling is, let us see. What you should take care is pre-analytical tissue before you interpret. If a specimen comes from all the way from some village and comes to you after 2-3 days, gone case. You may not get the ISC very well. Or again, this chemotherapy and RT therapy is important, because if in a post-therapy status, you may lose expression of MSH6. Unnecessary over-testing will happen. So proper fixation and history of therapy. So let us see, how do we interpret this? See, this is all 4 are positive. This is, you gave it as MMR proficient. The chances of MSI less likely. If you see MSH2 and MS6 positive and MLH1 and PMS2 is negative, it can be sporadic or Lynch syndrome. How do you identify? You do BRAF mutation. If BRAF is positive, highly unlikely that it is a Lynch syndrome. So BRAF becomes important there. So BRAF indirectly tells you that you are not dealing with a Lynch syndrome, even though MLH1 is and PMS2 are lost. Now, if you see MSH2 and MSH6 are lost, likely Lynch. If it is only MSH6 lost, then also likely Lynch, but you should rule out radiotherapy and chemotherapy. Then if only PMS2 is lost, then also it could be Lynch. So in general, there's a very strong concordance of both IHC and your MSI. Yes, I can see a lot of people feeling sleepy, so I'll skip this. So what you understand is, what you should take care is the tumor, if the control is weak, repeat, or go for MSI straight away. If you have absence staining, focal staining, repeater stain, or go for MSI. So remember, I can ask you a question. How do you check MMR? By IHC. How do you check MSI? By PCR or NGS. That's it. You should understand what is the methodology. So now you have different staining patterns. I think I'll skip this. I already told you BRAF, once you have a BRAF positive, very unlikely that it is Lynch, so it's going to be bad, poor prognosis. It will be bad prognosis. Now, you have to access a little more of your brain. Now, this is the case. This one more pathway which I have not told you. Okay. Now, this is a case, 67-year female, very highly influential, from Punjab, they had come. My daughter is a surgeon, son is a chartered accountant. You see the perforation, tumor perforation is there. So when you're seeing the tumor, it is gray white, very firm, necrotic, and you see the type of number of tumors. I have added all the tumor list here. Adenocarcinoma. So no need of remembering, impossible to remember, at least remember the higher grade variants. So what is your diagnosis here? Morphologically? Morphologically? Okay, higher power. Lymphoma? ALCL? Anything else? Undifferentiated carcinoma? Undifferentiated carcinoma also agreed, right? Now? So we did all the ISCs, it came negative. Okay? We did everything. We thought it is a high-grade non-Hodgkin's lymphoma. We did everything, came negative. Then, at this point of time, please understand, you are not a Turumkan. You don't understand, take a second opinion. It's very important because you are trying to save the patient, right? Your aim is to say you're not able to understand, take a second. So I took a second opinion. So what happened is, this I sent to one of my friend. So he said, this is showing a rhabdoid morphology. So rhabdoid morphology is one tumor in colorectals which will behave aggressively. But see the report here. This mark A4, mark B1 and all those things, this is all was retained, but this shows mismatch repair loss. So what does it tell you now? Patient can be treated, high tumor mutation burden, patient can be treated. The patient was put on immunotherapy. Last 4 years, she is still alive. It is an aggressive cancer. So that is the role of pathology there. If you are able to identify rhabdoid, you don't have the markers, at least get the markers done. Do a minimum MMR and say MMR is deficient. See this is tumor, this was lost. MMR was lost and it came to be a MMR deficient rhabdoid carcinoma, undifferentiated carcinoma rhabdoid. So this, if you read this report, gone case, but last 4 years, she is still alive. There's one more entity known as switch sucrose, vagara, SWA, SNF. This helps in remodeling the genetic material. So if you see a rhabdoid morphology, you should suspect. I hope this is important. Any tumor of pancreas or GI tract, look for rhabdoid morphology. Even though it is aggressive, at least in GI tract, it may be amenable. If it's MMR deficient, it may be amenable to immunotherapy. Nothing else works. No chemotherapy will work for her. Okay, so now this is the last slide is just to understand how this PDL1 works actually. If you see, all of you have got iCards, right? All of you got iCards. So suppose you want to enter into this thing, you show the iCard and go, or you show your face or a fingerprint, right? So this is, so PDL1 is something like a iCard. Every cell will have some iCard. Every cell will develop that, so it shows that ligand binding. Okay, it's ours, go. So this is a cartoon just to understand. This is a cell with PDL1, this ligand, and the cells do not have, these tumor cells are killing them, right? So what the tumor cell also become tricky, it become one PDL1, it will develop one coat, false iCard, and try to escape. Now you give immunotherapy, PDL1, then it will break this, it will not allow these cells to bind, and then the cells will get, that's how the immunotherapy works. So this is the latest thing. So you are supposed to say. So this, I close with this. So as is our pathology, so as is our practice. Thank you.
Thank you, sir, for sharing your valuable insights in the GI pathology. So I think postgraduates had understood what are the things to be concentrated during grossing, and also the consultants, which thing has to be reported during the routine reporting of the CAP protocols and all. Thank you, sir. Sir, I request Satish Rao sir to please come on to the dais, and I request Dr. PJ Naidu sir, Priyanka ma'am, and all the organizing committee members in the Department of Pathology to please felicitate Satish Rao sir. All of you, come on to the dais, please. Thank you, sir. All the faculty, come on to the dais to felicitate Satish Rao sir.
We will now break for lunch.
There are only few questions. First 13 will be MCQs. You will be distributed the papers. You just tick which is the correct option. And 14th and 15th questions are match the following. We have given the numbers. You write the corresponding alphabet, which is correct. Okay. And after that, you have the fill in the blanks or one word answers. Write your name and college name also. I want to make a note. I haven't shown this PPT even to my faculty. Even my postgraduates, they don't know the what are the questions. So they are also participating in this. They are participating genuinely. Okay. Once you are ready, I'll start. Okay. Are you all ready? Next slide, please. Okay, this is the first question. In reflex esophagitis, basal zone hyperplasia is defined microscopically as basal layer thickness exceeding. So when you say it as a basal cell hyperplasia in case of reflex esophagitis, 10%, 15%, 30%, or 50%. Don't discuss, write whatever you know. Second question, which of the following factors is most strongly associated with poor prognosis in esophageal squamous cell carcinoma? Whether it is tumor located in the upper one-third of the esophagus, TP53 mutations, tumor with extranodal extension of the lymph nodes, or the presence of perineural invasion. So from these pictures, you identify what is the correct answer. See the endoscopic findings. See the microscopic picture, what you can see, and that is the pass stain, and it is positive. Next. Okay, from this picture, identify what it is giving the clue to you.
Somebody is prompting the answer. Do it silently. So fifth question, it is a picture of a duodenal biopsy. So what it could be? Identify the microscopical findings, and from that what you can say. Sixth question, which laboratory test is most useful in confirming autoimmune gastritis? Increase in serum gastrin levels, antiparietal cell antibody test, stool antigen test for H. pylori, serum anti-intrinsic factor antibody. So from these pictures, identify the disease. Eighth question, what is the first line of treatment for H. pylori early stage gastric mal lymphoma? Early stage gastric mal lymphoma. Write whatever you know. Don't ask or don't discuss. So ninth question, which syndrome is associated with multiple GIST? Gastrointestinal stromal tumors, multiple GIST. Tenth question, which of the following dysplasia patterns in long-standing IBD most strongly mandates colectomy? Indefinite for dysplasia in flat mucosa, low-grade dysplasia in a polypoidal lesion, or multifocal flat high-grade dysplasia, or isolated DALM completely resected endoscopically. Eleventh question, what is the diagnostic cutoff for subepithelial collagen band thickness in collagenous screw? I think it was discussed in the morning. Or it is collagenous colitis. Twelfth question. The earliest and the most characteristic histopathological feature of acute gastrointestinal graft versus host disease. Crypt abscess, villus blunting, crypt epithelial apoptosis, and lamina propria fibrosis. Thirteenth question. A 62-year-old woman with an appendiceal mucocele undergoes laparoscopic excision. Post-operatively, she develops abdominal distension and mucinous ascites. What is the most likely complication? Post-op ileus, pseudomyxoma peritoni, perforated appendix, intra-abdominal abscess. Fourteenth question. It's a match the following. Okay. Uh, the disease conditions are Barrett's esophagus, second is Whipple's, third is cirrhosis of liver, fourth signet ring cell carcinoma, fifth is chronic pancreatitis, sixth is ischemic colitis. And the strains, the list of strains are A. Morhoff's Van Giesens, B. Mason trichome, C. PAS, D. Alcyon blue, E. Music Carmine, and F. Von Kosa strain. Shiva, lights. Oh, this question carries 3 marks. Fifteenth question. Match the disease condition with the specific gene mutation. Shall I change? Sixteenth question. These are picture-based questions only. A 32-year-old woman presents with an intermittent lower abdominal pain, constipation alternating with the diarrhea, and pain during defecation. On examination, there is tenderness in the posterior fornix. Transvaginal ultrasound is inconclusive. Identify the picture, microscopic picture. That is an endoscopic picture. I have given a clue. Where do you see such type of picture, endoscopic picture? Eighteenth question. Identify the organism and what is the special stain that has been used here? Right, which is used on the right side. I can hear the answers from the faculty. I want faculty to. This is a radiological picture, which is a classic picture. Twentieth question. 32-year-old male presented with loose stools for 3 weeks, associated with abdominal bloating and weight loss. What is your diagnosis? 21st question. 40-year-old man presented with profuse watery diarrhea associated with abdominal cramps and low-grade fever. It's your gross diagnosis. Question number 22. Question number 23. So slide for diagnosis. Question number 25. It is also a slide for diagnosis. This is the last question. Identify the diagnosis. What is the diagnosis of this picture? Those who have completed, you can give your papers to the faculty. Oh, this is the last one. Shiva. Answers. Did you all give your papers? Okay. So what is the answer for this first question? C. It should be more than 30% to call it as a basal zone hyperplasia in case of reflex esophagitis. So what is the answer for this? So always lymph nodal invasion is a poor prognosis. What is the answer for this? It's Whipple's disease. Why not xanthelasma? It's PAS negative. Good. Lipoma, the picture will be totally different. Okay. Signet ring cell carcinoma, as they are uniform and there is no atypia, does not. What is the answer for this? It is a radiological finding seen in achalasia cardia. So what is the answer for this? It is not intestinal metaplasia. You can see this is I said it is a duodenal biopsy, and here you can see gastric type of glands. So it is a gastric heterotopia. What is heterotopia? Normal tissue in a abnormal cell. So which test is most useful in confirming autoimmune gastritis? B. Antiparietal antibody test. So what is the answer for this? Zollinger-Ellison. Why Zollinger-Ellison? In Zollinger-Ellison, what will happen? There will be increased HCl production. Okay. And it is a case of miniaturous disease where there will be weight loss. And you can see this classical picture. Okay, rugosity is prominent vascularity. And there will be anorexia. And there will be protein loss. So they usually present with the edema. It is a case of miniaturous disease. What is the answer for this? Yes, H. pylori eradication therapy. Even though it is an early stage of mild lymphoma, the treatment is H. pylori eradication therapy. So what is the answer for this? NF1. Multiple GIS will be seen in NF1. So which of the following dysplasia patterns in long-standing IBD most strongly mandates colectomy? Very good. It is multifocal, flat, high-grade dysplasia. So what is the diagnostic cutoff for collagenous colitis? More than 10%. Normal thickness? Less than 5. Very good. I think the questions are very easy. Okay. What is the earliest picture in graft versus host disease? Apoptosis. Crypt epithelial apoptosis. What is the normal count in a crypt? Less than 1. 1 or less than 1. Okay. Very good. It's a case of pseudomyxoma peritoneum. So what is the stain that you use for Barrett's esophagus, which will be positive? Alcian blue. Very good. For Whipple's, as we have discussed earlier, it is PAS. And cirrhosis of liver for fibrosis, mass and trichome. Signet ring cell carcinoma, mucicarmine. It is epithelial mucin. For epithelial mucins, we use mucicarmine. For chronic pancreatitis, Van Cossa stain, because there will be calcifications. Calcification can be seen by Van Cossa stain. Ischemic colitis, Verhoef's Van Giesens. It will stain the elastin, not collagen, it's elastin. Okay. So, what is the mutation in FAP? APC gene. For PJ syndrome, STK11. Lynch, it is very easy. MLH1 and MSH2. Neuroendocrine tumors, ATRX. Signet ring cell carcinoma, CDH1. Juvenile polyposis, SMAT4. Very good. So what is the diagnosis? Endometriosis. You can see the endometrial glands and stroma in the lower part. Okay. So what is this? It's not autoimmune gastritis. Strawberry vascular. Which vascular vein? Post hypertensive ectasia. Gastropathy. Post hypertensive gastropathy. So, what is the organism? H. pylori. What is the special strain for that? Vathin star. Very good. What is this? Apple core deformity. Where do you see? Not inflammatory. Carcinoma. Okay. There will be a narrowing of the lumen resulting in this apple core deformity. So, what is the answer for this? The picture is small. You can see some organisms on the luminal surface epithelium. You can't see it. Okay, it's a case of giardiasis. You can go with the clinical picture also. Loose stools. So what is this? This was shown morning in the morning. There are something in the lumen on the luminal side. What are those organisms? You're right. Cryptosporidium. It's a cryptosporidium. What is this? You can see some air bubble like appearance. Where do you see? Pneumatosis, cystoides intestinalis. This is very easy. What are the eye changes? Kaiser Fleischer rings. And there will be cirrhosis of liver, enlargement of the liver due to deposition of copper. What is the special stain for that? What is the stain? What is the stain for copper? Rhodanine. It's rhodanine. So it is very easy. Stronger lines. Enterobius vermicularis. Very good. Hirschsprung's disease. Okay, what is this ACHE showing you? Acetylcholine esterase in an abnormal location and it will be increased in case of Hirschsprung disease. Where is the pathology actually in this? Proximal part, not the dilated part, proximal part. There will be a ganglion. Thank you.
Thank you, ma'am, for the interactive session.
We request ma'am to come up on the stage and Dr. PJ Naidu sir, HOD of Department of Pathology, and all the faculty members to please come up on the stage to felicitate ma'am.
Thank you, sir, ma'am.
Moving to the slide seminar.
We invite Dr. B. Gautami, ma'am, Associate Professor of Department of Pathology, Jemson Hospital, to come ahead and conduct the session.
Yeah, good afternoon, one and all. So, how was the quiz? It's nice, good. You will have exciting prizes also. How did you answer? It's okay. Okay, you can come forward. Huh? So, moving on to the next session, we are going for slide seminar. So, let's move to case 1. So, a 61-year-old male presented with tenesmus, bleeding PR, and he consulted a local RMP, stating it to be hemorrhoids. Okay. On examination, there is a 3 into 3 centimeters a nodular mass noted in the anal region. So, I would some photographs are taken from the internet source for the purpose of seminar. So, this is the clinical picture. Yes, any clinical diagnosis? PGs, hemorrhoids. DDs, other anything else? DDs, hemorrhoids, carcinoma, colorectal carcinoma. Okay. Anything else? Anything else? Skin tags can also be like that, isn't it? So all these are your DDs. Now let's go into the microscopic picture. And you said also carcinoma. Yeah. Now let's see. So can any postgraduate read the slide? Any one of you? Can you read the slide, ma? How are the cells? Okay. Hyperview. Now what do you find here? How are the cells? Okay. Okay. Amma? Prominent. Okay. 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 High NC ratio, you mean to say prominent nucleoli is there. What are these? Carcinoma. Okay. Any others? One said poorly differentiated carcinomas. Anything else? Pages? Okay. So do you want any other ancillary techniques? What do you want? IHC. Which IHC you want? What is your doubt? What first you kept? What is the first DD you kept? Microscopically? Carcinoma. It is negative, ma. What else do you want? What else did you say? Lymphomas. Sorry, sorry. Even CD45 is negative. Leukocyte common antigen. It turned out to be negative. Muzzle. Your Carl Desmin are negative. What do you want? Excellent. What melanin marker do you want? What else? Can anyone read? It is a membrane, yes, sir. It is membrane. Huh? It is membrane. ఎక్కడరా న్యూక్లియస్ ఆల్ అదర్ న్యూక్లియస్ బ్లూగా కనిపిస్తున్నాయి కదరా. ఇట్ ఇస్ సైటోప్లాస్మిక్ పాజిటివిటీ ఇజంట్ ఇట్? జస్ట్ see the picture. It is a cytoplasmic positivity of melan A. Then do you want, what else marker do you want? Okay, now can you read out the slide? This is also positive marker, isn't it? So now come up with the diagnosis. Melanoma. You don't find pigment? Good. So it is mucosal amelanotic melanomas. So how are these melanomas different from cutaneous melanomas, mucosal melanomas? Is there the prognosis and everything is same, or any variations are there? They're same? They are same? Which will have a better prognosis, cutaneous or mucosal? Yes, mucosal melanomas are at having a poor prognosis compared to cutaneous melanomas. Can you say why? Can you say why? Late diagnosis. అంటే మనం తప్పు చేస్తున్నాము. Presentation late. ఇంకా? So by the time the patient presents to you, a mucosal melanoma will have metastasis. Why? Extensive spread through lymphatic channels is more in mucosal melanomas compared to cutaneous melanomas. So usually even the survival rate for a mucosal melanomas are very lesser, 5 years survival rate compared to a cutaneous melanomas. Okay, and usually what is the function of these melanocytes? Can anyone say? Then why melanocytes are present in sun shielded areas also? In genital tract, even there also it will be present. So other than protection and pigmentation, what else are the roles of melanocytes? Any other role? Yes, what you said is correct. That is the prime role of a melanocyte. So protection against the UV radiation. That is the reason why they are present in your epidermis and the dermis. Good. But it is also present in the mucosal areas like your oral cavity, your genital tract and all. So that is the reason why it is arising here, isn't it? Now, what could be the other functions of melanocytes other than, I think I'm audible like this. So what are the other functions other than this pigmentation and all for melanocytes? Could be some, it will have phagocytic action, isn't it? Antigen presenting cell, like it can act. Very good. Immunity. So it is one innate immune response. It acts as a member, your melanocytes. So those are some of the other functions of melanocytes other than your pigmentation and sun protection from the UV radiation. That is the reason why these melanocytes are present in other sites like your oral region and also your genital tract. So now all the risk factors for cutaneous melanomas will be like your exposure and radiation and all. What could be the risk factors for mucosal melanomas arising from oral cavity or in the anogenital region? You should also evaluate the risk factors, isn't it? That is why how we can go for surveillance and all. So what could be the etiological factors? Good. Smoking, yes. So smoking explains oral mucosal melanoma. Okay, accepted. But our case is a case arising in the anal region, right? Good. Rather than HPV, usually HIV associated will be more common. I would like to note this point, all the postgraduates. HIV association is considered to be a risk factor for the mucosal melanomas arising in the anogenital region compared to your HPV. Okay. Some other infections can also cause, your virus infections can cause, but they usually cause oral or mucocutaneous melanomas. Whereas in the anogenital region, the risk factors will be your HIV individuals. Okay. So with that, we are, any doubts? Shall we move on to the second case? Good. Now second case, a 10-year-old female child presented with abdominal pain and constipation. On ultrasound, it suggested her to be intussusception. That means the patient is having some obstruction. This is the brief clinical history. So on clinical examination, you could find this, okay, and on endoscopy, these are the findings we noted in the endoscopy also. So from this, Or how, to what you can come? What else do you? Two zigzags, just jumping. So where else do you find this pigmentation? Ma? Juvenile polyposis. Okay. For to call it as a familial adenomatous polyposis, what is the minimum number of the polyps should be present? Minimum it should be 100. The multiple polyps has to be present, isn't it? There can we explain this pigmentation? Okay. So now this is the whole mount specimen. So can you read out the slide? Scanner view. Very good, very good. Just how is the slide you just say? Well, you just describe a slide, then you can come to the crux point. How are the mass? Polypoidal mass, yes. Then do you want one more view? Chibilovillus? Okay, you are saying the pattern of these glands and all. Okay. As you said, there is a central arborization of the smooth muscle cells. Yes. So this diagnosis now Eugig's polyp syndrome. Okay. Now, when do you call it as a Peutz-Jeghers syndrome? Correct. What's your diagnosis is correct. Okay. When do you call it as to be a Peutz-Jeghers syndrome? That is a histopathological view. That means which type of polyps we call that PJ polyps? Hamatomy. Only one boy is answering. Why others? He is dominating or what? So we shall ask him to keep silent, then others can talk. What is? I don't mean that. I want all the other students also to speak as like you. That will be boosting even to me, isn't it? Okay. What is defined a hematomatous polyp? Anywhere? When do you call it as a hematomatous polyp? Okay, if they are not, so you answer. When do you call it as a hematoma? Hematoma or epurantum? Hematoma. Yes, you are saying correct. Abnormal proliferation. Yes. Abnormal proliferation at the normal cell. The reverse of that is called as choreostomy. Yes. So there is an abnormal proliferation of the normal cell. That is hematomatous polyps are there. There is mucocutaneous pigmentation around the lips and the oral cavity, or mucocutaneous pigmentation is there. And there is also autosomal dominant type of inheritance pattern is usually observed. Then when together, this triad we call it as PJ syndrome. So when I am saying it is autosomal dominant type of inheritance, what will be the penetrance to the offspring? 50%, isn't it? So what is the gene most commonly involved in PJ syndrome? STK11. So for the patients of Peutz-Jeghers syndrome, you have diagnosed the case, then we can leave as such, or we need to say anything to the patient. So what is important in these individuals? What is more important in these individuals? Counseling. Regarding what? See, a 15 years old child came to you with a polyp. Now what you will guide or what you counsel that child? A preventive colectomy, that means prophylactic colectomy, you need to say. Prophylactic colectomy is done in only particular cases, like your APC gene mutation, where there is 100% chance for the child to turn into malignant. So you should do a APC gene mutation. If it is positive for them, then only go for prophylactic colectomy. Not for simple PJ syndromes or not. Don't do a prophylactic colectomy. Isn't it not? The standard of the living of the child is completely lost if you go for a prophylactic colectomy, isn't it? So what else do we do? Surveillance. Excellent. Surveillance. Surveillance for what? Surveillance for what? What are the risks? These individuals are prone for what? Less chances. Okay, extra GI, I will give it to you. Other than GI, what tumors are common? Other than GI. Other than GI types. GI malignancies are okay. Colorectal malignancies or adenomas can occur. Okay, accepted. Other than GI, genital tract cancer. Rather than endometrial, breast carcinomas are more common. That's why surveillance with mammography is indicated for all these children. Because breast malignancy, 30% increased risk for breast malignancy is there. Yes, good. As what you said, FGT is involved, but not endometrial carcinoma. Anything else? One specific, usually associated in PJ syndrome? Yes, ovarian tumor. Which ovarian tumor? Not granulosa. Very good. Sexpert stromal tumor with annular tubules differentiation. That tumor is more commonly associated with PJ syndrome. Okay. So for a PJ syndrome or 15 years trial, when it is coming to you, so surveillance is more important. Go for regular mammographies, go for regular pap smears, go for regular ultrasound, pelvis or testicular to screen like that. Surveillance is more important in PJ syndrome. Okay. Any other doubts? Shall we move on to the next case? Doubts? Yes. Shall we move? It is easy, isn't it? A 45-year-old female presented with abdominal fullness, significant weight loss. So on endoscopy, there is mucosal nodularity with a on endoscopy, there is a mucosal nodularity with a reddish polypoidal lesion on the greater curvature of the stomach. So these are the endoscopic. I'm not giving any endoscopic pictures. I'm giving the endoscopic findings. So a middle-aged female presented with abdominal fullness and there is weight loss. And on endoscopy, there is mucosal nodularity. Are we clear? So this is a scanner view. Can you read out? Can you read out more? Better view you want? No power view? No? Can you read out? Now can you read out? How are the yes? Anyone post-graduate? Please read out. How is the mucosoma? Gastric gastric biopsy. Gastric biopsy. Do you want anything else? This is a microscopy. Do you want anything else? Yeah, అన్నిటికీ ఐహెచ్సీలే కావాలి మీకు. So rely on first our microscope, our morphology, తర్వాత ఐహెచ్సీ కావాలి. మన మార్ఫాలజీలో మీకు ఏమనిపిస్తుందో కొంచెం చెప్పండి. Inflammation. So inflammation, stomach. So I want some diagnosis. No problem if you are wrong also. అమ్మ చెప్పింది ఇన్ఫ్లమేషన్ నేను చెప్తున్నాను కదా ఇది ఎండోస్కోపీ ఫ్రమ్ ద టేకెన్ ఫ్రమ్ ద స్టమక్ అండి ఇది గ్యాస్ట్రిక్ బయాప్సీ ఇన్ఫ్లమేషన్ ఉంది సో ఐ వాంట్ lymph node. Okay, you just if I give 2 slides, if you get 2 slides for second opinion, you will see you will write like this. Any parasite is there. You will write one report. You will write one report. So give that report I must. ఇన్ఫ్లమేషన్ ఉందని మీరే చెప్తున్నారు కదా ఎందుకు పాలిప్ అక్కడ పాలిప్ ఏం కనిపిస్తుంది యూ ఫైండ్ ఎనీ పాలిపాయిడల్ లీజన్ ఐ am saying polyp from the endoscopic view. Endoscopist is saying some polypoidal mass is there, then also nodular. Okay, in microscopy could we find that polypoidal mass? Now, what stain is this? What is statistic? Now, H. pylori positive వచ్చింది గోల్డ్ అంత ఇన్ఫ్లమేషన్ ఉంది మరి ఇందాక మీరు ఇన్ఫ్లమేషన్ అన్నారు కదా సో డూ యూ వాంట్ ఎ బెటర్ వ్యూ సారీ సార్ lymphomas. Okay, can you read out the cell? How do you read this slide? One of you can, you don't need to stand, you just read the slide. Monocytoid cells, uniform monocytoid cells with irregular nuclear contours, isn't it? Some cleaning is there, occasional, yes, some ATPI is there, yes, ATPI is there. Okay, so in this slide we have this one. What is this in the second slide? Towards your right side, you could see multiple, something called as lymphoepithelial lesions. What is the lymphoepithelial lesions called as? When do you call it as a lymphoepithelial lesion? Your so-called your centrocyte-like cells or your lymphocytes are going and destructing your gastric gland. When more than 3 lymphocytes are, when more than 3 centrocyte-like cells are going and destructing your gastric glands, then a suspicion should rise in your mind. These are some lymphoepithelial lesions. Though that means it is not a case of simple gastritis. So simply after seeing these 2 slides and after seeing H. pylori, you should not report it as H. pylori gastritis. So So you should move on to the next item view, where then you could find some ATPR. So now you want markers. Which markers do you like? Now you ask for IHC. Now you first find out the cause. What is the cause for this much of inflammation? So some organism is causing this much of inflammation and gastritis. Now you jump into the diagnosis. Now gastritis is there. Markers you want. What marker? Inca. Pink. So this came out to be positive for CD. So what marker positive? This marker is positive. So you could which type of state. So whenever you are getting a slide of IFC, you should read out where it is positive, diffusely positive or not, whether it is nuclear, cytoplasmic or membranous. Always the PG has to read a slide of IFC like that. Now it is membrane stain positive, diffuse intense positivity is there for CD, BD. Got it? You are very good at okay. Now one more thing. It also is positive for kappa to lambda. There is a restriction of light chain. That is intense positive is there for kappa chain, isn't it? Now these are neoplastic cells, and they came positive for B cell markers. There is H. pylori association, and there is light chain restriction. Okay, monoclonality is there. Good. Clonal expansion of cells is present. That's what. Good. Now come up with the diagnosis. H. pylori is there, nodal proliferation is there, B cells are there. Wow, excellent. Cheppu correct? What do you say? So H. pylori associated maltomas. Now H. pylori associated, why I am saying H. pylori associated maltomas? 50%, mostly what is the most common site for extranodal lymphomas? Most common site for extranodal lymphomas. In GIT, stomach is the most common site for your extranodal lymphomas. Okay. Now here, 50% of the cases are associated with H. pylori. Can anyone describe what is the pathophysiology going behind that? For the maltoma to occur? అంటే ఎలా వస్తుంది అని ఇంటి హెచ్ పైలోరీ ఇన్ఫెక్షన్ అయినంత మాత్రాన మాల్టోమా రావడం అని చెప్పి ఒక సింపుల్ ఇన్ఫెక్షన్ ఒక ఆర్గానిజం ఒక లింఫోమా కాజ్ చేయడం ఏంటి వాట్ ఈస్ హ్యాపెనింగ్ దేర్ నో ప్రాబ్లమ్ ప్లీజ్ ప్లీజ్ Okay. Normally, your H. pylori attracts all your B cells and neutrophils and all. So they cause it to be proliferation. Then reactive oxygen species can be released from your neutrophils. Same your general pathology will be applied here. All the reactive oxygen species can cause the genetic mutations. Later on, go with additional oncogenetic mutations. Thereby, it can transform into DLBCL also. Right? Diffuse large B-cell lymphomas transformation can also occur. Because simple maltoma, if it is a low grade, isn't it? Low. Can you simply say when you classify lymphomas, how do you classify HL lymphomas and HL lymphomas? Again, in NHL lymphomas, how do you classify B cell lymphomas, T cell lymphomas, isn't it? In B cell lymphomas, prognostically, how do you? I need to say, I'm not. They are going into deeper, but prognostically, when we see whether it is B cell lymphomas or T cell lymphomas. Again, B cell lymphomas with low K67 index or low grade, better survival rate and higher, isn't it? What are those low grade or lower? That means small sized centrocyte like cells. Low grade lymphomas, usually B cell lymphomas. One is what we said, extranodal marginal zone lymphoma. ఇంకా అది హైయర్ కదా లోవర్ కేస్ అండి ఫస్ట్ లోవర్ ఎఫెక్ట్ హై CLL bar SLL very good. Follicular lymphoma, marginal zone lymphoma, mantle zone lymphoma, mantle lymphoma, yes. CLL bar SLL, follicular lymphoma, all these are some low grade. Higher grade and again comes your DLBCL. T cell in a plastic large cell lymphoma, higher grade. Usually. Okay, now let's go for the IHS. Now, which markers usually gets positive in your marginal zone lymphoma? B cell markers. చెప్పండి ఏంటవుతుంది CD19, CD20, CD79A, yes, your BCL2, your PAX5, your kappa to lambda restriction, all these will be seen in your marginal zone lymphoma. Typical for mantle cell lymphomas, CD CD5. CD5, CD10, cyclin D1 will be positive for mantle cell lymphoma. Follicular lymphoma? Yes. CD10 and BCL6 will be positive for follicular lymphoma. CLL bar SLL? CD5 and CD23. CD5 and CD23 will be positive for CLL bar SLL. So those should be considered when you think a case of lymphoma arising from your gastric organ, gastric biopsy. Okay. So that's all about your H. pylori associated maltomas. Okay. So what is the first line of therapy for H. pylori associated maltoma? Eradicate H. pylori. Till how long? How much year? 1 year, 2 years, 3 years, 10 years. So we should have that, no? Okay, that is not our headache. Okay. But usually we should wait for 24 months. At least 2 years the first line of therapy will be only eradication of the bacteria. Till then the individual is persistence of the bacteria. Then go for chemotherapy. Isn't it? Because maltoma, so go for chemotherapy. Are we clear? Shall we move on to the next case? Case 4. A 35-year-old female presented with perianal itching, pain, bleeding. Young female presented with bleeding, pain and itching. On examination, there is about 2 into 2 centimeters nodule with an intact surface. Young female presented with itching, perianal itching, pain, bleeding. On examination, there is 2 into 2 centimeters nodule with an intact surface. Okay? Do you want more for this? Can you read out the slide? Can you read out the slide? Read out the slide. One more view. Just చెప్పండి రా ముందు మీరు డిస్క్రైబ్ చేయండి తర్వాత డయాగ్నోసిస్ చెప్పండి. Very good. A well circumscribed lesion is noted within the dermis. Overlying epidermis is intact or not having any connection with the underlying tumor. That's what you want to say. Yes. So next type of view you want? Now? Okay. How is it lining? Okay. Till now, benign or malignant? Benign. In the benign, only dermis is involved, more circumscribed in nature, and even these hypo cells are not showing any much epithelium. No, it is benign. Cool. If it is benign, next what? Next type of view? Sorry, sir. Next type of view? What are the cells? How is the lining? How is the lining? Yes, you are right. Apocrine? Apocrine? Metaplasia. Is the apocrine? Okay, apocrine differentiation is there. So apocrine differentiation is there. A dermal nodule, not having any connection with the overlying epidermis. Suddenly stroma is like this. So what is the broad diagnosis? You are saying it's a benign tumor. So what could be the diagnosis? Head neck cell, excellent. This is first head neck cell. From now, in head neck cell tumor, what category? What category? మీకు హార్న్సిస్ ఇవన్నీ కనిపిస్తున్నాయా? సో పాలిక్యులర్ డిఫరెన్సియేషన్ ఏమైనా ఉందా? లేదు. ఇంకేంటి పాలిక్యులర్ డిఫరెన్సియేషన్? Eccrine or apocrine? So you are having decapitation secretions of there. So what tumors you know in the apocrine or apocrine differentiation? You said it is head neck cell tumor, benign tumor. You are saying there is a different apocrine differentiation is there. So now you see, now you categorize the disease. Gatiga. Adenoma, papilloma. So the answer is hydradenoma. So you could see multiple capillary configurations. Confined only to the dermis. Overlying epidermis is free. Why we are more concerned overlying epidermis is free, overlying epidermis is free? With the epidermis is involved, what will be the differentiation? Other differentiation. If epidermis is involved, additionally papillary configurations are there. Cyst, papillae, or like epidermis is involved. Plenty of lymphoplasmacytic cells is there in the stroma. Syringocystelinoma papilliferum. Yes. Syringocystelinoma papilliferum is one more thing you should come into mind, your papillary lesion. But in syringocystelinoma papilliferum, overlying epidermis will be connected. Whereas in hydrogenoma papilliferum, there is no connection with the overlying epidermis. Okay. So shall we move on to the next case? So whenever you could find a mass near the anal region, don't always jump it to be anal carcinoma. It could be a neck cell tumor, it could be any melanoma, or it could be anal carcinomas, or it could be polyps, anything else. Okay. In case 5, a 55-year-old female presented with fever, with recurrent episodes of diarrhea, abdominal pain. So, with elderly age group, 55-year-old female, now presented with fever, with recurrent episodes of diarrhea and constipation. On endoscopy, large, deep, linear, punched out lesions are noted. So, large, linear, punched out lesions are noted in a older female. Shall we go to the pictures? Good. Inclusions. What inclusions? Intracytoplasmic inclusions or intranuclear inclusions. So you could also find some reddish granules within the cytoplasm. So on IHC, those cells came out to be positive for CME. So before jumping into the diagnosis, you should first rule out your others like your recursive colitis or inflammatory bowel disease where hip distortion is there. Nephritis, cryptasis are there. But if you find intranuclear inclusions or intracytoplasmic inclusions are there, and recurrent episodes of diarrhea like that means pointing out towards immunodeficiency, then consider the diagnosis of CMV colitis. Okay, so here in CMV colitis, check for serology. So the titers will be 4-fold increase in CMV colitis, that is CMV antigen levels will be raised. In case 6, a 65-year-old male presented with abdominal fullness, dyspepsia and upper GI bleeding. So elderly male presented with dyspepsia and upper GI bleeding. This is the endoscopic picture. So how is the endoscopic picture? Okay. A polypoidal mass is noted. Okay. These are the pictures. So scanner view. Scanner view. How is the mucosa? How is the mucosa? Involved or uninvolved? Uninvolved. Where is the tumor? Where is the so-called lesion proper lying? Just beneath the mucosa. That means in the submucosa, the lesion is lying. So how are the cells? Stellate cells. One more view you want? Now you read out. What else do you find? Okay. Anything else you found? It is a what till now what we learned? It is a submucosal lesion. Some stellate cells are there, and mucosa is free. You are saying. So and what till now what comes to your diagnosis? Benign or malignant? Something it is benign only because we could not find any atypical cells even on low power or high power. Mucosa is not involved. In submucosa only something is there. So now come up with the differentials. Myxoma. Why myxoma? So you could find that myxoma and that bluish hue, that mixture change is found. What is gist? Okay. What are the markers for gist? CD? CD117. CD117. See, what is your CD117? What else do you want? Huh? Dog one you want? Your dog one is also negative. So CD117 is negative. Your dog one is negative. And then how could I call it as GIST? It is no longer GIST. Something else? 5%. Inflammatory fibroid polyp. So it come out to be positive for which marker? So there is positive for CD34. There is onion skinning of this around the vasculature. Onion skinning of the pattern is present, and CD34 came out to be positive. And there's actually plenty of inflammation. No one said that. See, whatever things we are seeing is all the eosinophils in the second sphere. So there's a plenty of inflammation is there, and polypoidal mass is there. And CD117 and dog1 came out to be negative. It is a submucosal lesion. So mucosa is completely freed out, and CD34 is positive. So it is an inflammatory fibroid polyp. Okay. So can now you say what are the this is inflammatory fibroid polyp. Okay. What are the lesions? Usually any lesions of GIT which are sparing mucosa? Can you say? What lesions usually spare mucosa? I think I'm clear in my question. This. Okay. This. Very good. Your endocrine tumor. Amma? Yes. All your lymphomas and all. So whenever you get a gross specimen like this and the mucosa is free on cut section is defined, these possibilities should come to your mind. So it is sparing the mucosa, so it is no longer your carcinoma, carcinoma. So it is something arising somewhere else. So whether it is this or lymphomas or your neuroendocrine pathology. So that's all about the slide seminar. I hope I have not confused you. Good.
Thank you, ma'am.
We request ma'am to please come up on the stage, and Dr. PJ Naidu sir, HOD of Department of Pathology, and the faculty to please felicitate ma'am.
Thank you, sir. Thank you, ma'am. We proceed to the grossing session. This session will be conducted by Dr. PJ Naidu, sir, Professor and HOD, Department of Pathology, Jameson Hospital.
So here is the prize winners for today's quiz. Second prize, Dr. Sheikh Jeeva Akhtar, GEMS Medical College. I request Dr. PJ Naidu sir, HOD sir of Pathology, to give away the prizes to the winners.
Second prize, Dr. Zeba Akhtar. Now, first prize, Dr. Edla Jagdish, AMC, Andhra Medical College, Vishakhapatnam. Thank you.
for you in your upcoming days. Hope it is utilized by you all. Thank you.
Thank you, ma'am. We request you to stay on the stage for a minute. We request Dr. PJ Naidu, sir, HOD of Department of Pathology, and faculty members to please felicitate ma'am. Thank you, ma'am. Thank you, sir. We request Dr. PJ Naidu, sir, to please stay on the stage, and the faculty members of Pathology Department, along with Sai Lowry, ma'am, to felicitate, sir. Thank you. With this, we come to the conclusion of today's CME program.
We request Dr. V. Pavani ma'am, Assistant Professor, Department of Pathology, Jensen Hospital, to please come forward and deliver the vote of thanks.
Good evening, esteemed dignitaries, guest speakers, and all delegates. It's my privilege and honor to propose the vote of thanks as we conclude today's insightful sessions. We sincerely appreciate our sessions conducted by our chief guest, Dr. I. Satish Kumar, and all other guest speakers for sharing their vast expertise and knowledge with us. And we would like to extend our special note of appreciation to our dean and resource persons for their unwavering support and vision in making our this event reality. We are immensely thankful to all students and technical staff for ensuring smooth conduct of this session. We are also thankful to all the participants sitting here for the active involvement and interactive sessions for this throughout CME program. And we also extend our sincere gratitude to our observer ma'am for your valuable feedback for this today's session. Finally, special thanks to our HOD sir and all other faculty for your tireless efforts and valuable contribution for making this program successful. Thank you everyone, and let's have a tea and snacks. Okay, thank you so much.